Good afternoon and welcome to this virtual Ready Seniors workshop. My name is Allison Albright and I'm the Regional Preparedness Liaison for FEMA Region 2. I'm going to provide a few technical considerations before we begin. Today's proceedings are being recorded and captioned. The archived event will be available on the FEMA website in the coming weeks. You should hear audio through your computer speakers, so please ensure your volume is turned up so you may hear the proceedings accordingly. In the top right corner, we ask if you'd like to receive news and updates for Region 2. If so, please enter your email address and we'll be sure to add you to the distribution list. We will have a question and answer session after the presentations with time permitting. You'll see a Q&A pod in the lower right-hand corner. Please feel free to submit questions about the subject matter there, and time permitting, we'll do our best to answer them. Finally, the presentations from today will be available for you at a later date. We will send those out to you, and there are some resources available now in the file share pod. You can click on those files using the download button. With that, I'd like to turn it over to the Region 2 Community Preparedness Officer to introduce our speakers and today's proceedings.
Thanks, Allison. See if we can get our technology in sync today. Did you know that FEMA's #1 goal in our strategic plan is to build a culture of preparedness? The Region 2 Individual and Community Preparedness Program is focused on preparing individuals and communities for disasters by providing useful information and training, inspiring people to act and be ready for any emergency. Good afternoon. I'm Debbie Costa, the Community Preparedness Officer for FEMA Region 2. On behalf of our team working to strengthen preparedness across New York, New Jersey, Puerto Rico, and the U.S. Virgin Islands, I'd like to welcome you to our preparedness webinar. As part of that goal, we're pleased to be hosting today's webinar in partnership with the U.S. Department of Housing and Urban Development. Why am I reading? I'm reading the wrong script. So you will have to all forgive me because I have two different webinars today. So let me get on the right page with everybody so that I can say exactly who I'm hosting today's webinar with. My apologies to the audience. So since 2017, FEMA Region 2 has partnered with HHS's Administration for Community Living, Substance Abuse and Mental Health Services Administration, Centers for Medicare, Medicaid Services, New York State Office of the Aging, New York State Association on Aging, and Ventura County, California Area Agency on Aging to present over 17 Ready Seniors events throughout FEMA Region 2, and most recently for a national audience via virtual delivery. This program has provided over 1,000 attendees from various senior care provider organizations like Area Agencies on Aging, Senior Housing, Meals on Wheels, dialysis centers, community centers, outreach groups, with an overview of business continuity planning, planning for senior citizens, mental health aspects of disasters, facility requirements, and lessons learned from real disasters. Typically, these workshops include an interactive tabletop exercise. However, due to COVID-19 vaccination efforts, we're unable to execute that portion of the workshop today. We do hope to do so at a later date. The objectives for today's presentations are to examine and improve the processes that senior care providers perform during pre-disaster operations, to provide for continuity of services to our senior populations, discuss the actions of senior care providers during power outage or similar events with the expectations of enhancing services for our senior populations, inspire and encourage senior service providers to empower their clients by being conduits of preparedness messaging for senior populations and their families to empower them to be better prepared for disasters. On today's agenda, you will be hearing from several federal agencies, a state agency, and a case study from an area agency on aging. We'll have a short break halfway through the presentation, and time permitting, we'll have Q&A at the end that will be moderated by Rhonda Schwartz from the Administration for Community Living. Just as a reminder again, the video function is only for our presenters to use. I'd like to now pass the mic to Kathleen Oddie, Regional Administrator for Region 2, Administration for Community Living, to provide some opening remarks. Kathleen?
Thank you so much, Deborah, and hello everybody that's attending our webinar today. Just want to offer a few welcoming remarks because I think you know the old term, forewarned is forearmed. We've all heard that saying before, but throughout the nation, facility-based care has been required by law to practice evacuation drills and plan for disaster. But what we do know is increasingly older adults with complex health issues live alone in the community, and many times they are far from their relatives and their caregiver. And as a result, these older adults depend upon our community service providers for necessities and psychosocial supports, both prior to, during, and even after a disastrous event. Ready Seniors Training is a shining example of a partnership that's committed to prepare providers and organizations to take pride and to build resilience while providing critical services to older adults in their communities. And I know providers are aware how important these critical services are during a disaster. And they also know the demand for critical services dramatically increases when there is a service disruption or when older adults are impacted during a major disaster. Within the last year, some of our agencies saw a dramatic increase in the demand for home-delivered meals due to the pandemic. Some of these agencies actually saw a 55 to 60% increase in demand. The services our aging and disability networks provide literally mean the difference between life and death. Today, the Region 2 FEMA team, the Administration for Community Living, wish to really thank you, all of you who are attending, our aging and disability service providers who've demonstrated total commitment to serving your population under extreme conditions and circumstances. Following today's training, you're going to walk away with all kinds of new resources, new ideas, renewed sense of how you can continue to provide services and supports during challenging times. Therefore, on behalf of Region 2 FEMA, ACL, our wonderful presenters, we welcome you to today's presentation. Glad you're with us. Hang on, it's going to be a wonderful, wonderful afternoon. I'll turn it back to you. Thank you so much for attending.
Thanks, Kathleen, and thank you. I extend the same gratitude to everyone for attending today. We are going to kick off today with a very brief overview on continuity of operations, or COOP. And what it is a federal initiative required by presidential directive to ensure that federal agencies are able, and there goes my slides, are able to continue performance of essential functions under a broad range of circumstances. COOP plans must be capable of implementation anytime, with and without warning. Agencies must have implementation plans and procedures in place for emergencies that occur with or without warning. They must provide full operational capability for essential functions, not later than 12 hours after activation in all circumstances. And they must be capable of sustaining operations for up to 30 days. Agencies have to develop operating procedures and acquire resources necessary to sustain operations. They also need to include regularly scheduled tests, training, and exercises to ensure that COOP plans are viable. If our audience or participants today would take a moment, maybe they could type in the chat some instances when they think we might use COOP or when they might need to use COOP. See the chat, but I don't see anybody writing. Oh, now we have multiple attendees writing. So a wildfire, a flood, absolutely, hurricanes, earthquake, and a COVID pandemic. How true. So there are 10 primary elements to any good COOP plan. And for lack of time, we are very briefly going to maybe just define some of them. Probably the most important is essential functions. And what essential functions are, they are the critical activities performed by organizations They are the agency's business functions that must continue with no or minimal interruption. Orders of succession provide for the orderly and predefined assumption of senior agency offices during an emergency in the event that any officials are unavailable to execute their legal duties. Delegations of authority are formal documents specifying the activities that may be performed by those who are authorized to act on behalf of the agency head or other key officials. If continuity activation is required, an agency's primary operating facility may be unavailable and essential functions will require relocating. So you need to choose an alternate site to conduct your essential functions. Continuity of communications provides the capability to perform essential functions in conjunction with other agencies until normal operations can be resumed. Essential records are categorized as emergency operating records, which are required for agency essential functions during and after a continuity event, or rights and interest records, which are critical to carrying out an agency's essential legal and financial functions. Personnel need to be adequately trained and cross-trained to enable the performance of all essential functions. And a TT&E program provides the framework for promoting consistency and uniformity of mission readiness activities. Devolution is the capability to transfer statutory authority and responsibility from an agency's primary operating staff and facilities to other employees and facilities. So in Region 2, our devolution area would be Region 5. So if Region 2, FEMA, was impacted in such a way that we were no longer able to perform our essential functions, those responsibilities would devolve and Region 5 would carry them out for us. And lastly, reconstitution talks about how an agency attempts to restore operations to its primary facility. So I know I went over a lot of terms that you may not be familiar with if you don't currently have a COOP plan or if you haven't considered continuity of operations. And I would encourage you to take a continuity training. FEMA has a number of courses that are available online, and FEMA Region 2 typically provides training on COOP as well throughout the course of the year. Unfortunately, the pandemic has sidelined us a little bit in our efforts, but if you don't already subscribe to FEMA Region 2 News, we do announce those trainings as they become available. So if you've never heard of continuity before, or if you've never heard of COOP, and you say, you know, that's new, if you are already doing data backup and recovery, if you already have come up with a way to do employee alerts and notifications, you've already thought about an emergency operation plan, then you are familiar with some of the elements that are most important for a continuity plan. So when would you use COOP, right? We talked about it a little bit earlier: hurricane, earthquake, pandemic. They're all different times when you might use COOP, and it might not even be an event that impacts an entire area. It could be an event that maybe only impacts your facility. What if you have a broken water main on the corner? Or I've spoken with some people where the power in their one facility was fried. Only in their facility. It didn't impact any other businesses. So the short answer to when you should use COOP is any time an emergency impacts your facility or your ability to perform your essential functions. And I think of essential functions as a fundamental duty of your agency. They are considered crucial and at the very core of what your agency does. So for a long-term care facility, an essential function in its simplest terms would be caring for individuals who may not be able to care for themselves. Any of the items listed on this slide may impact your ability to continue to perform your essential functions, like fires, flooding, power outages, and even civil disturbances. So there are lots of continuity planning considerations. So when an organization is faced with a continuity event, the continuity plan will provide for continuation of essential functions, and it will enable a rapid response to any emergency situation. The continuity plan should document what will occur in a continuity situation, how and how quickly continuity actions must occur, where continuity operations will occur, and who will participate in continuity operations. An organization's capability to perform its essential functions rests on 4 pillars: leadership, staff, facilities, and communication systems. Leadership is critical to provide support for continuity planning and ensure continuity of essential functions. Staff must be sufficiently trained and cross-trained to perform their duties in a continuity environment. Facilities must be adequate, separate locations to ensure execution of essential functions. And communication systems and technology must be interoperable, robust, and reliable. So I know that we've gone over a lot of information in a very short amount of time. I would encourage you to check out some of the resources and training websites for continuity of operations. And of course, you could always reach back to myself or anyone at FEMA Region 2 to support your quest for a more robust emergency operation plan, including COOP. So here is my contact information. And with that, I will turn the mic over to Rhonda Schwartz. And before I do, Rhonda is the Regional Administrator for Administration for Community Living in Region 3. That includes Pennsylvania, Delaware, Washington, D.C., Maryland, Virginia, and West Virginia. She will be the moderator for the duration of the workshop today. Thank you. Rhonda, it's all yours.
Thank you, Debbie. I appreciate it, and it's a pleasure to be here with all of you today. Thank you for joining us. Now, in Debbie's presentation, she was asking everyone to look inward to see how you can make sure your agency is prepared to continue operations in the event of an emergency. And in my presentation, you'll see I'm going to be asking you to look outward, to look towards your community and how you may be able to assist older adults in your community. Now, we all know older adults are disproportionately affected by disasters. In the 2017 California wildfires, the majority of the victims were reported to be over age 70. According to the CDC, more than 70% of the people who died due to Hurricane Katrina were older adults, while people 60 and older only accounted for 15% of the population. And thinking about Hurricane Maria, which hit Puerto Rico in 2017, it was reported that Puerto Rico saw very large increases in deaths from causes such as hypertension, renal disease, and diabetes during September and October 2017, right after the hurricane, as compared to the average of the previous 2 years during that same time period. Now, some of you may recognize the photo that's in this slide. It's a very powerful photo, and you may have noticed that it was included in the FEMA presentation as well. This photo was taken at a nursing home in Texas during Hurricane Harvey. The story goes that the nursing home, when they saw water was coming into the facility, reached out to first responders for assistance, but were told first responders were not able to get to them. Finally, when the water got to this level, again, it was reported that someone associated with the nursing home tweeted out this photo, and finally, after the water got to this level, they were able to evacuate folks. Now, more and more frail older adults are living alone in the community, as my colleague Kathleen Oddie mentioned during her opening remarks. With advances in medicine, people are living longer. And as you know, there's been a trend nationally for many years for more people with a nursing home level of care to remain at home with support. This has been a positive development. People can stay home, and it typically costs less to provide care in a home than it does in a nursing home. But with this rebalancing of the long-term services and support system, more people are living in the community who are frail and who have limited mobility. And as Kathleen also mentioned in her opening remarks, families are living further apart today. With technology and, absent COVID, the ease of travel, people have been more inclined to live further from family. During the current pandemic, we also are seeing a disproportionate effect on older adults. According to CDC data, more than 80% of deaths in the United States from COVID-19 are among adults age 65 and older. This slide, hopefully you can see it, it's a little bit small, but it shows the number of COVID-19 cases by age. I downloaded this slide from CDC's website on March 13th. As you can see, as of that time, just over 14% of the COVID-19 cases have occurred among adults age 65 and older. Slightly more than 20% of cases have occurred in the 50 to 64-year-old age group. Now this slide, which I also downloaded from CDC on March 13th, shows death counts by age. Now as you can see, while as I mentioned with respect to the previous slide, adults 65 and older account for just over 14% of total COVID cases, they account for more than 80% of COVID deaths. Also, according to CDC data, as of January 10th of this year, there were just over 130,000 deaths from COVID-19 among nursing home residents. This slide from CDC, also downloaded on March 13th, shows hospitalization data during the pandemic. It's hard to see, but the data is from March of last year through early March of 2021. The red line represents adults 65 and older. The dark blue line just below it represents adults ages 50 to 64, and the light blue line are adults ages 18 to 49. So as you can see, we have in recent months, thank goodness, seen a dramatic decrease in hospitalizations. According to the COVID Tracking Project, as of March 4th of this year, long-term care facility residents accounted for 34% of U.S. COVID-19 deaths, while they only represented 1% of the total U.S. population. I'm just going to say that again because it's an extreme statistic. Long-term care facility residents as of March 4th of this year accounted for 34% of total U.S. COVID deaths, while they only represent 1% of the total U.S. population. Now, the effects of disasters go far beyond the direct damage caused. In Puerto Rico, during October and November 2017, a couple of months right after Hurricane Maria, there were more than 5,500 reports of elder abuse. That's in those 2 months alone. They had more than 5,500 reports of elder abuse. That's almost half the number of reports for the entire previous calendar year. Now, a complete picture of the effects of COVID-19 on elder abuse remain to be seen. The National Center on Elder Abuse points out that social isolation is a risk factor for elder abuse. This current situation, during which older adults have been practicing social distancing, could make them vulnerable to bad actors who might try to take advantage of them financially or otherwise. Also, relatives may be far away or may not be able to provide the care and attention that they might in other times. Families are undergoing stress, which also could lead to abuse. Self-neglect may be increasing, in particular as many older adults don't want to allow caregivers into their homes at this time. Adult protective service programs have faced unprecedented challenges over the last year in the performance of their duties. Again, the full ramifications of the pandemic in this regard remain to be seen. While it may be a while before we have a full picture, ACL has started to receive some preliminary data. ACL funds the Adult Protective Service Technical Assistance Resource Center, known as APS TARC. Its website address is apstarc.acl.gov. The Resource Center did a study on the impact of COVID-19 on adult protective services based on surveys it conducted of adult protective services programs. You can find a link to the study on TARC's website. And here are some of the key findings from that study. 81% of the respondents had received fewer reports of adult maltreatment since the pandemic started. That's a lot, 81%. Slightly more than half of the respondents indicated that the level of client need had increased, while 42% saw no change in need. Nearly one-half of the respondents indicated that, on average, there was no change in client willingness to engage with the adult protective service programs due to the pandemic, while nearly the same percentage indicated that clients were, in fact, less willing to accept assistance from adult protective services. 57% of the respondents indicated that there was less investigation of cases as a result of COVID-19. That's a lot. 57% indicated they were doing less investigation of reported cases because of the pandemic. Half of the respondents indicated that they were limited to providing fewer services to clients. 24% showed no change, and 20% did indicate they were providing more services due to the pandemic. When it comes to the number and types of maltreatment reports, most respondents indicated that there was no change in the types of adult maltreatment their clients were experiencing. Nearly a third of the APS supervisors were seeing a small increase in cases of self-neglect. 23% saw a large increase in cases of self-neglect. 31% of APS supervisors also reported an increase in financial exploitation cases. Now, having made my case for the disproportionate effects of emergency situations on community-dwelling older adults, this is the point in my presentation when I pivot to taking a look at what community-based organizations that serve older adults can do to prepare for emergency situations so they will be in a better position to provide the important supports that adults need. Historically, this is where I talk about how we need to learn how to be resilient with respect to all disasters. That communities can be most resilient when they take a whole community and an all-hazards approach. That the response can be better when community organizations work together. I don't think I need to tell you that today. You most likely have experienced that yourselves during the course of this pandemic. So now I'm asking you to take stock of the lessons you have learned. Look at where you have faced challenges, how you address them, and how well you address them. What challenges were you not able to meet? What could you do differently? What services have been most important, and how did you shift your focus to meet needs? Also, think about the connections you have made during this emergency. Think also about other connections you might be able to make with other providers to handle other emergencies that you are likely to face in your community. Are there particular services or supplies that you need in an emergency? Are there certain partnerships you have developed during this emergency in order to assist vulnerable older adults? Think about making arrangements during non-emergency times to make sure those services and supplies are in place when an emergency occurs. Think about how you might maintain those connections during non-emergency times. so they will be in place and ready to activate when the next emergency happens. Think about how you might turn all of this information into an ongoing emergency preparedness plan. Now, I want to talk to you about an example of a partnership that developed out of a disaster. I learned about this from a report from an annual symposium that was held by the New York City Emergency Management Agency. Red Hook is a neighborhood in New York City that was cut off immediately after Hurricane Sandy. First responders were not able to reach the area. Neighborhood residents on their own got together to check on those in need and assisted their neighbors until help could arrive. This experience led to the development by the Red Hook folks of a community emergency readiness plan. It's posted online, and you can see it at readyredhook.org. This slide shows a screenshot of that plan. This map from the Red Hook Emergency Plan shows the locations of support services, and it also shows how various groups and organizations partnered on the plan. For example, it shows food and shelter being provided at a church and assistance with utilities being provided at a local retailer. The Red Hook Emergency Plan also includes things such as a timeline of what to do 72 hours before and after an emergency, tips on preparing a disaster plan and an emergency supplies kit, evacuation and non-evacuation tips, and what to do about pets. Like the Red Hook folks, you can take these partnerships that you have developed and lessons that you have learned and turn them into a longer-term preparedness plan so you will be better prepared next time. I want to mention another example of something we heard about after an emergency event. In upstate New York, there was a flood that affected several communities. In one of these communities, there happened to be a waste disposal company. And that waste disposal company, after the flood, every week put dumpsters out in various places throughout the town so that people could get rid of their debris from their homes and their businesses. And by doing this, it was said that this town ended up being well ahead of the other neighboring towns in its rebuilding efforts because of this action by this one community member, this waste disposal company. Just thought that was an interesting example of an idea of something that a business could do to contribute to its community after a disaster. If you've heard of any other innovative ideas about a company doing something after a disaster, or if your agency has done something, please feel free to share those in the chat box. If I have time at the end of my presentation, I'll take a look at those. There are some local coalitions working throughout the U.S. You could look to them as examples, or you possibly could look into joining an existing coalition. One such coalition is Voluntary Organizations Active in Disaster, known as VOAD. It's a national coalition. It has been in existence since 1970, and it seeks to better coordinate the response to disasters. It's a coalition of national organizations, faith-based, community-based, and other nonprofit organizations, and 56 state and territory VOADs, which represent local and regional chapters throughout the U.S. You can go to the VOAD website to find the VOAD near you. VOAD volunteers provided more than 48 million hours of services in 2016. Services that can be provided include, but are not limited to, preparedness, repairing and rebuilding, and psychological assistance. The Medical Reserve Corps program is a program of the Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. The MRC is a national network of volunteers organized locally to improve the health and safety of their communities. The MRC network comprises nearly 1,000 community-based units and almost 200,000 volunteers located throughout the United States and its territories. MRC volunteers include medical and public health professionals, as well as other community members without healthcare backgrounds. You can find an MRC near you on the MRC website. You also can form your own unit. There are over 2,700 local community emergency response team programs nationwide, with more than 600,000 individuals trained since CERT became a national program. FEMA's Community Emergency Response Team program trains volunteers to prepare for the types of disasters that their community is likely to face. Through hands-on practice and realistic exercises, CERT members learn how to safely respond to man-made and natural disasters, help to organize basic disaster response, and promote preparedness by hosting and participating in community events. Healthcare coalitions are groups of individual healthcare and response organizations, such as hospitals and EMS providers, working within a defined geographic location to prepare for and respond to disasters and emergencies. The Assistant Secretary for Preparedness and Response Hospital Preparedness Program provides funding for healthcare coalitions. You can find the healthcare coalition that services your area online. I want to mention an emergency preparedness planning resource that is available. It's called the Capacity Building Toolkit for Including Aging and Disability Networks in Emergency Planning. It was developed by the Office of the Assistant Secretary for Preparedness and Response with input from ACL and others. Topics covered include such areas as assessments and preparedness planning, identifying older adults and people with disabilities, how to do effective messaging, supporting evacuation and transportation needs, addressing sheltering and housing needs, and legal advocacy for older adults and people with disabilities. Now, some interesting innovations have grown out of this emergency. One example that my colleague Kathleen Nadi, I think, touched on at the beginning of the webinar is partnerships that have developed between older nutrition programs and restaurants. So as Kathleen mentioned, we've seen a tremendous increase in the demand for home-delivered meals as a result of this pandemic. Some of the nutrition programs were not able to deal with this tremendous increase in capacity. At the same time, you had restaurants with excess capacity that really could have used some revenue. So what some nutritionists have done in some areas is they have partnered with the restaurants. The restaurants provide catering services, and in some cases, they might even help to deliver meals if they have refrigerated trucks. Other things that have taken place are daily check-in calls. Many agencies are doing those for older adults, so they at least hear from someone on a daily or some other intermittent basis. Some agencies have done car parades to drive by older adults' homes and let them know that people are thinking of them. Some agencies have partnered with technology or phone companies to provide phones and tablets to seniors. Some have hosted virtual congregate sites so that people can virtually have a meal together, or they've conducted educational activities or classes virtually. Some other activities that I heard of through our states are very interesting that I want to mention to you. One is the Maryland Department of Aging's statewide Caregiver Service Corps program that they developed out of the pandemic. The goal of this program is to enable older adults to remain in their homes with support systems in place that they may need. The objectives of this program are to provide backup support for informal caregivers of older adults who are unable to provide care due to their own illness, exposure to COVID-19, or some other temporary constraint. The program has a call center staffed with trained specialists who are available 7 days a week and can quickly evaluate the needs for older adults and identify volunteer caregivers and other resources to deploy to these older adults' homes. The kinds of supports that can be provided are assisting with an individual's self-administration of medications, help with transferring and delivering of essential groceries. Now in Virginia, AAAs, Area Agencies on Aging, I should say, have reported various interesting activities. One agency provided vegetable seeds for older adults who were in their own homes, together with instructions for planting. One AAA conducted bingo over the telephone with its clients. One agency included in home-delivered meals art and notes from children who were enrolled in their daycare program. In one agency, they made socially distanced visits on Mother's Day to older adults with vases filled with fresh flowers from gardens of community members. Some other ideas include things such as leveraging social networking platforms to share content and encouraging messages, as well as helpful resources, offering computer-friendly services to support new users of electronic devices, identifying virtual events such as online concerts and museum tours, delivering groceries or activity books. And in one case, we heard of a tribe that did a very low-tech but interesting activity. They created bingo cards, and each square in the bingo card had some activity that the tribal elder could be doing at home alone in their own home to keep them busy. And they played bingo every week. The cards were delivered at the beginning of each week and then were collected at the beginning of the next week. And prizes were awarded to folks who won bingo that week. So that was just an interesting idea. These are just some of the ideas that we've heard of. Please feel free to share any other ideas that you've heard of also in the chat box. And again, if I have time at the end of my presentation, I'll try to go back and take a look and we can talk about those. Now, oops, I think I just did something wrong there. See if I can, there we go. Okay. Oh, I'm still doing something wrong here. I can get rid of that. Is that better? There we go. Okay. Now, several of the ideas that I just mentioned relate to combating social isolation. Social isolation and loneliness can have a devastating impact on our health and well-being. In fact, a recent study found that social isolation can be as bad for your health as smoking 15 cigarettes a day. Social isolation has been a major issue during the pandemic for older adults. To tackle the challenge of combating social isolation during COVID-19 and beyond, the Administration for Community Living pulled together partners from across federal government, the Aging and Disability Networks, philanthropy, and industry. Together with its partners, ACL has created the Commit to Connect campaign. It's a public-private partnership that is building a nationwide network of champions to collaborate on solutions and help us reach more people, developing an online, consumer-focused tool that matches people who are socially isolated to customized suggestions for resources that can help them to connect and engage. Establishing critical partnerships in communities and across all levels of government, sharing successful initiatives that can be implemented in communities across the country, and more. The Commit to Connect campaign challenges each of us to do our part, to connect and engage ourselves, to reach out to others to help them to do the same, and to work together to create tools and resources. You can sign up for email updates about the campaign on ACL's website. If your organization offers programs, services, or technologies that can help people connect to others or engage in the community, or both, please let us know about them. On our website, you will find resources for states and aging and disability networks. For example, ACL's Elder Care Locator and Engaged, the National Resource Center for Engaging Older Adults, which are both funded by ACL and administered by N4A, put together a flyer containing suggestions for how older adults and people of any age can prevent social isolation and loneliness while staying safe. This customizable flyer is available in English and Spanish. The Engaged National Resource Center also has put together a 6-part series of sample grab-and-go blog posts that organizations can use to promote the importance of older adults staying engaged. Also available on our website are ideas that we have learned of from states as well as social isolation risk assessment tools. It's an exciting innovation, and please visit our website for more information. Now, in trying to assist vulnerable older adults in your community, you may need to locate older adults who are not your clients. These are some of the important ways that agencies have found older adults in need of help during this emergency. The first one you see on this list, local community leaders, it's incredibly important. People listen to their local community leaders. So if you can find those folks, they will not only be able to help you find people who need assistance, but they also will help you to get those folks to listen to your message. Houses of worship could be a good place to find older adults. Local utility registries, because older adults may have registered with them, as well as special needs registries. Of course, 211 and 911 have been important places for people to locate older adults. I want to mention another, not sure what that was. I want to mention another resource. I think I went too far. Let me see. There we go. Okay. In 2013, ASPR expanded its partnership with its Centers for Medicare and Medicaid Services and launched the HHS Empower program to harness the power of Medicare programs data. The program initially included at-risk population data for those who relied on electricity-dependent durable medical equipment. The program was later expanded to include chronically ill at-risk populations who relied on certain healthcare services such as dialysis. Community organizations can use Empower's publicly available tools to access readily available de-identified data on the number of electricity-dependent at-risk Medicare beneficiaries in a geographic area in order to assist with community emergency preparedness and response. State and territorial public health authorities use this Empower emergency planning data set to conduct targeted public health activities related to emergency management. In the event of an emergency, an authorized state or territorial public health authority may submit an official request for data to the data set to provide public assistance and outreach. And I'm going to tell you about an example of how this was used. In July 2020, the Philadelphia Department of Health wanted to reach individuals age 65 and older and those with chronic health conditions, populations at a higher risk of adverse health outcomes due to COVID-19 infection. Using information from the data set, the Philadelphia Health Department sent postcards containing important public health and safety messaging and resources to approximately 13,000 at-risk individuals who were included in the data set. The postcards advocated for the at-risk individuals to stay home and to be safe, to wear face coverings, to socially distance, and to monitor their chronic health conditions, as well as staying in touch with their providers by telehealth or other phone lines. The postcards also provided direct phone numbers for individuals to call if they needed access to grocery delivery or other support services. They could also get assistance with paying utility bills or if they had questions related to COVID-19. The Philadelphia Department of Health also piloted a phone outreach activity in order to better understand and respond to the challenges, needs, and behaviors of these at-risk individuals. By looking up their phone numbers, the health department was able to provide telephone outreach to a random sample of older adults, reaching 80 individuals who volunteered to participate. The Philadelphia Health Department was able to obtain valuable information from this telephone survey that has helped to inform its COVID-19 response. The discussions during the phone surveys also allowed the health department to reinforce the messages that had been contained in its postcards. Another benefit of the Philadelphia Health Department's use of the Empowered data set was that by reviewing the home health care agency contact information in the data set, the health department identified 2 agencies that had not been included in other agency lists they had received. The health department was able to reach out to these home health agencies and assist them in reducing the risk of COVID-19 exposure, both for their own staff and for their clients. Now, in addition to preparing your own organization for an emergency, it also is important that older adults and their caregivers prepare for emergencies. Events can happen without warning. Official assistance may be delayed, and it's important that everyone be prepared. It's important that people understand the resources of the federal government are limited. We cannot assume that we can just pick up a phone and receive immediate assistance. We need everyone to take as much personal responsibility for their own safety as they can. For our folks who don't believe that they need to worry about a disaster happening where they live, how many times have you watched a news story about an area that was flooded or out or had some other kind of emergency, and shocked residents have reported living there for 50 years or longer and they've never had such a problem? We need to try to reach people in our communities and to get them to understand the need to be prepared. Local community leaders may be able to help with this. As I've mentioned before, people listen to their local leaders. It's really helpful to find these folks and have them help to get the message out to people in our communities. These are some of the basic but very important elements of preparedness. Be informed, have an emergency supplies kit, and make a plan. Very basic, but very important. You can find more information and guidance for older Americans in preparing for disasters from the Ready.gov website. These 3 tips come from their brochure, Preparing Makes Sense for Older Americans, Get Ready Now. It's a great brochure. It's got great information. It's easy to understand. I highly recommend it. Now, before making a plan, it's important to understand the needs of the older adult. They need to be assessed. What assistance might the older adult need? What can he or she do for herself? What resources does she have? Can the older adult evacuate in an emergency? Evacuation is a huge consideration. If you are fortunate enough to have advanced knowledge of something that may be coming, like a hurricane or some other event, and if you think it's possible that the person you're caring for may need to be evacuated, take advantage of that time that you have ahead of time and evacuate them if possible, because it may be impossible to evacuate them once the emergency happens. When you're thinking about all of this preparation, please don't forget to think about the older adult's possible assistive technology needs. Does the older adult have equipment that requires electricity or batteries to operate? Might he or she need a backup wheelchair or other equipment? When it comes to evacuation, have a plan in place for what would be done if an evacuation were recommended or needed. Waiting until you're hearing that the emergency is upon you is not the time to do this evacuation or other planning. Do this planning during a non-emergency time when you can think about what the best way will be to address all of these issues. When it comes to evacuation, think about things such as, would the older adult be able to transfer easily into a car and out of a car? Where would they go? Where would they stay? Is the facility that they would go to accessible? Now, assistive technology can be high-tech and also can be low-tech. Each state receives funding from the Administration for Community Living under the Assistive Technology Act of 2004. These grants support state efforts to improve the provision of assistive technology to individuals with disabilities. This program makes assistive technology devices and services more available and accessible to individuals with disabilities and their families. The AT program in your state may be able to provide information regarding planning for emergencies. For example, it's possible they may be able to refer you to someplace where you can get an additional wheelchair that isn't motorized so that you have a backup in case the older adult has a motorized wheelchair and they might not be able to use it if they run out of power. They may be able to help you find extra equipment, but just also help you think about the considerations for planning for older adults who may have different kinds of disabilities. You can find much more information about the Assistive Technology Program on ACL's website. I want to, I don't know if I skipped something. I'm not sure. Okay. This next slide, sorry about that. Wasn't sure if I skipped a slide, but I don't think I did. This next slide contains preparedness tips for older adults and caregivers. These are just things that we've heard about and that I've even experienced myself personally in an emergency. First, it's important to understand the risks that the community is likely to face so you can plan for those. Enroll in the local special needs emergency registry. Most communities have them, some don't, but most do. Note also that you often may need to register for those registries annually. So keep that in mind. You may need to do it every year. Try notifying the local utility company of any needs for power, for medical equipment. You may be able to be put on a priority list for getting your power restored if you're on if they're aware of your needs. Get to know your loved one's neighbors so they can possibly help you out in an emergency. Keep portable cell phone chargers on hand. And of course, arrange for backup in case the primary caregiver is not available. Also, try signing up to receive official communications in an emergency. Lots of communities have apps that you can sign up for these days that you can get a warning on your phone if an emergency is coming. And finally, this last tip comes from me. This is from my experience. Back in the early 2000s, I was working in New York City, and one summer we had a blackout, completely unexpected. And I was working in a law firm at the time, and one of the partners in the law firm happened to carry lots and lots of money, cash on him as a result of 9/11. Because of that emergency, he always made sure he carried a lot of cash. And he had me actually walk up and down the floors of our law firm and hand out $20 bills to people, because I think we're all in the habit, especially in this high-tech time when we don't really use much cash, I think we're all in the habit of not carrying a lot of cash on us. And I know it can be difficult to carry cash, but try to keep some cash on you, because if you have a blackout or some other kind of power outage, that's all you're going to be able to do to purchase things is use cash. And also, I also learned this from that emergency, it's important to try to keep gas in your car in case you have to leave. I was fortunate in that I had half a tank of gas in my car, so I was able to leave Manhattan and get out of town and go stay with relatives outside of the city who had power. But if you don't have gas in your car, you're not going to be able to go to a gas station and get gas, so just keep that in mind. Before I finish up today, I want to mention another tip. This is the Disaster Planning Toolkit for people living with dementia. This toolkit was created by the National Alzheimer's and Dementia Resource Center. It's made up of 7 tip sheets and checklists for people living with dementia, their families, and others, including friends and neighbors. It covers such things as planning for a disaster, important contacts, emergency supplies checklist, medical conditions and care needs, disaster planning tips for people living alone with dementia, and tips for communication and responding to dementia symptoms. I frankly think this toolkit is useful for all older adults, but you may find it particularly useful for people living with dementia. This last slide contains some resources for older adults and their caregivers. These are federal resources. I believe that these slides are being shared broadly so that you don't have to worry about writing them down, but I think you may find them to be helpful. I want to finish my presentation with just some key takeaways from my presentation today. First, it's important that we all keep in mind that the resources of the federal government are limited, and it's important today that communities work together to assist their own with response. Now, we're not asking you to do anything that would put you, your agency, your staff in any kind of risk or danger, but we're asking you to think, like that waste disposal company that I mentioned in upstate New York, what might you be able to do to contribute to your community in the event of a disaster? At one workshop that we held, we heard of an agency had an idea in upstate New York where there was a lot of snow of partnering with a snowmobile club so that they could go and check on folks and also provide home-delivered meals. We heard of an idea of an agency in New York City, which has a lot of high-rise buildings, of partnering with a local running club so that those folks who were in better shape could go up and down the steps of buildings and help the agency to check on folks. Second takeaway item, it's important, make arrangements with partners during non-emergency times to make sure you have the resources in place that you will need to operate in the event of an emergency. And finally, it's important to educate older adults and their caregivers in your community about the importance of being prepared. And again, enlist community leaders in your efforts to engage older adults. I can't stress enough the importance of that right there. I want to thank you all for joining me today. I don't think I have time to go through the chat, but we will take a look at anything that folks may have listed in the chat as far as any innovative ideas and other ideas for combating social isolation that you may have mentioned in the chat box. We will be sure to take note of that. I am now going to turn the webinar over to Dr. Jean Bennett, our next speaker. Jean is the Regional Administrator for Region 3, which again includes Pennsylvania, Delaware, the District of Columbia, Maryland, Virginia, and West Virginia. Jean, I should say, is the Regional Administrator for the Substance Abuse and Mental Health Services Administration. Jean has many years of experience in developing and implementing emergency preparedness plans, among her many other talents and experience. And Jean, the floor is yours.
Thank you, Rhonda. Let me just do a sound check. Allison, can you hear me okay and see me okay?
I can hear you, but I don't see your video.
Here we go.
There we go. Perfect.
And I don't know if you take my slides down until I need them, if it will improve people's viewing experience, but I will not need them for a bit. So I figured you might have seen a lot of slides and wanted a break from that. So I'm going to start without slides and then have some towards the end of my presentation. So good afternoon, everyone. Thank you to the organizers and my colleagues who are speaking. And thank you for the 200 plus attendees that are paying attention today for our important workshop. Imagine it's 2005 and Hurricane Katrina is about to hit Louisiana. Your elderly and frail grandmother has been cut off from all communications and is stranded in a flooding apartment and does not have a plan for what to do. Imagine that on top of her flooding apartment, your grandmother has a mental health or substance use disorder, and there's no plan. So now imagine instead if you had understood the why, when, and how to use existing resources at the Disaster Technical Assistance Center of the Substance Abuse and Mental Health Services Administration and had employed those resources in advance. You could have put a plan in place so that your loved one would not be caught in the situation of being cut off and possibly in danger of losing their life. In my 10 years experience in emergency preparedness and response at Children's Hospital Boston, the Department of Veterans Affairs, and the U.S. Department of Health and Human Services, and in my 10 years of experience as a regional administrator collaborating with state and federal aging program leaders, I've learned the importance of planning, and especially the critical role of family members in planning so that their elderly loved ones with special needs do not have to experience trauma during a disaster and can be helped to cope with challenges such as COVID. The solution is that you understand the why, when, and how to use the impressive array of resources at the Disaster Technical Assistance Center and can therefore decrease the worry, trauma, and possibly even the death of your very own loved one with a mental health or substance use disorder. Perhaps now you're wondering why there is so much emphasis on planning for older adults at the Substance Abuse and Mental Health Services Administration's Disaster Technical Assistance Center, which I'll now refer to as SAMHSA and DTAC. So now let's talk about the why. There are startling statistics from 2019. First, the National Survey on Drug Use and Health showed that 61 million Americans have a mental health or substance use disorder. Second, also in 2019, CDC data showed that over 70,000 individuals died from an overdose and that the majority of those overdoses were preventable because they were from opioids. More alarming, over 81,000 drug overdose deaths occurred in the U.S. in the 12 months which ended May 2020, the highest number of overdose deaths ever recorded in a 12-month period in the United States, according to recent data from the Centers for Disease Control and Prevention. And during COVID, the SAMHSA Disaster Distress Helpline had a 10-fold increase in the number of calls. Also, I wanted to add, on a personal note, I've had 5 family members' lives impacted by the prevalence of mental health or substance use disorders. So I'm imagining that you may know someone who's in that category too. Unfortunately, my mother and brother both died in separate car accidents caused when a driver who had a high blood alcohol level hit the car they were in. My mother died when I was 14 when the car she was in to her bowling league was hit. And my brother died when I was 23 on my first day in the Navy. He was only 18 and had an alcohol use disorder. He was out cruising with 17s, and he was the only passenger that did not survive the crash. Also, my nephew, who is my godson, was permanently disabled when he was hit by a driver who was 73 years old and had a high blood alcohol level. Worst of all for me, I had a close family member die by suicide when I was 1 year into this job. So I'm reminded every day about the importance of helping family members who have behavioral health disorders. And by behavioral health, I mean mental health or substance use disorder. I realize I may have made some of you uncomfortable by sharing these personal stories. I'd like to learn from you through an anonymous poll question, a simple yes or no poll. Do you know someone or have a family member with a mental health or substance use disorder, including an alcohol use disorder or depression? So Allison, could you please launch the poll? And we have a lot of people, so it might take folks a minute to switch gears and figure out how to answer the poll. And then once you figure that out, optionally, and this is more personal, some folks may not want to do this, if you want to enter into the chat the nickname, name, or initials of a loved one you've lost to suicide or overdose, or someone you know that died from suicide or overdose, go ahead and put that in the chat. It'll give you a chance to tell a little bit of your story. So as you can see from the poll results, it really validates the National Survey on Drug Use and Health, and making me a little tearful and choked up that I'm seeing all these initials. But I can't, unfortunately, I can't say that I'm surprised, but I think what you'll find is that a lot of people who work to help people with mental health and substance use disorders do so because they've had a personal experience of losing someone they love. So thank you very much, everybody, for that. So your poll and our losses are the main why. So now let's lighten things up a bit and talk about when to develop that customized plan to prepare your loved ones or the citizens you are responsible for in your jurisdiction. Anyway, I hope you're already wondering, when should I start planning for my loved one? Well, the answer is the sooner the better. If you start planning now, you could invest a very small amount of energy and have a well-defined way of going about it that is predictable and fairly easy. That's what this little ball represents. So as you can see, it's a very organized set of colors. They all fit together. It's a nice, smooth surface, and it's sort of predictable. If you roll this along the floor, you know exactly what's going to happen. So if you start early, this is how much energy that you could spend developing a plan. Now, let's suppose you wait until, say, the week before you see the hurricane model aiming directly for your community or your loved one's home. The amount of planning may be more than twice as much as that first, ball that I showed you. So it's probably hard to see, but this surface of this ball is rough and it's kind of squishy and it's not very pretty. So if you wait until you see that hurricane coming, it could be a lot more difficult and require more than twice the amount of time and energy, and you might not have as predictable an outcome. If you wait until just before the disaster is happening, things get very scary. There's a lot of different pieces to this. It's squishy, it's unpredictable, and you really don't want to wait until the disaster is about to hit. And I think it really emphasizes, this point emphasizes what you heard from our prior speakers. And that's why we talked about COOP, and that's why Rhonda talked about all those special details about what goes into a plan. There's a lot of different pieces to a plan, and at this stage, whatever plan you come up with is likely to be unpredictable. Finally, if you wait until you cannot reach your stranded grandmother, it may be impossible to avoid emotional trauma and physical harm to your loved one or community. So this is too big for me to even fit here, but as you can see, so I think that giant green ball represents what happens when someone is already unreachable and you're trying to figure out what to do. During my time as an emergency responder in Louisiana, I had the daughter of an elderly gentleman in Louisiana in a nursing home there beg me to help her find her dad. And she was calling from Florida, and I was actually at the FEMA response center, and she could reach me at the FEMA response center, but she couldn't reach anyone in Louisiana because the phone lines were down. We also had a case where I was called at the regional response center by an elderly woman who was overdue for her dialysis, and somehow when the rescuers went through her apartment complex, they missed her. And We were able to save her, but I think you get the point that planning in advance is really very, very important. So now that we've gone over the why and the when, let's introduce the how by talking about specific resources to illustrate that you, or a senior who is prepared and aware of a few key nuggets of information from the SAMHSA DTAC website, should know how to call, text, email, download, and participate in webinars or trainings, or read blogs, subscribe to recurring newsletters and other publications, or, really you could call your SAMHSA regional administrator. I would welcome calls like that, and so would the Assistant Regional Administrator for Region 3, and I'll be showing you a map of all of the regional administrators in the country, and I would definitely recommend you exercise that option if you're unsure how to proceed. I'll mention, before we go to my slides, I'll mention the top 2 resources I want you to remember. First, the Suicide Prevention Helpline is really important, and I think it's a widely known number. Toll-free number is 800-273-TALK. And second, anyone who's on chronic pain medicine that is an opioid should have naloxone and to have had training and know how to use that overdose reversing medication. So naloxone is the life-saving opioid overdose reversal medication, and that's important to remember and learn about. Family members are encouraged to carry naloxone, have training on it, and keep it with them at all times. SAMHSA.gov website has details about naloxone training and access, as do most local and state public health and behavioral health departments. Most of all, if you just remember the SAMHSA cheer, which is how to spell SAMHSA, so it starts like it ends with mental health in the middle. It's SA, substance abuse, MH, mental health, and services administration, SA, starts like it ends with mental health in the middle. You can find all the SAMHSA resources that I'm going to tell you about. And just remember, there's no sh in SAMHSA, which is the most common spelling error. But once you know SAMHSA.gov, then you can reach me, any of the regional administrators, or any of the resources that I'm going to tell you about. So Allison, can you please go to my slides now? Okay, so what I just described so far in my talk, I think fits into this one page, this one slide diagram. So if you look at those little green bubbles that are increasing in size from the bottom left to where it says preparedness resources, those are my little, the striped ball and the orange ball and the pink ball and the green ball. So the longer you wait, along the timeline, which you can see on the bottom, which is pre-disaster to post-disaster, the longer you wait, the more resources, energy, time, and that you'll have, and the less success. And the number of response resources will definitely increase as time goes by. But like Rhonda said, plans have to be very specific and customized for each individual. So when it comes to mental health and substance use disorders, this is very, very important. And so I have behavioral health specifics as a very large oval on the page. And I'm not going to go over a lot of the details about that, because I really just want you to remember that you can get help with customized specific plans, and that all that information is on our website. So I think and then the overall blue oval at the top, eliminating seniors' fears of disaster. Individuals with mental health and substance use disorders can have a more difficult time dealing with the threat of a disaster and the change and adaptations that are required because of one. So I think it just speaks to why we're really trying to emphasize planning in advance, and that there's lots of help out there. I would say to emphasize Rhonda's point, the federal government isn't going to be able to do everything for everyone in case of a disaster, but we do have a lot of really excellent planning resources, and we have a lot of willing federal civil servants that are very happy to be of assistance and think that you're contacting us about any issue, small or large, is perfectly fine. Okay, next slide, please. And also, I'm just going to say right here, I am leaving time at the end because I really want to engage. I want to see what your questions are and try to have folks that are attending get their questions answered so we can be a little more interactive. So I do have time at the end. So if you're starting to think of questions, please put them in the chat and we'll go back and get to those. So I'm really a fan of simple one-pagers that tell a whole story. So this is another example. If the only slide you keep from my presentation, and you will get this slide, this one would be a good one to keep. So SAMHSA has a coronavirus website that is constantly being updated and has all kinds of wonderful resources and guidance on it. So I listed that first because of this rolling coronavirus situation that we are still in after all this time, and that we're really not sure when it's going to be over. The SAMHSA Disaster Distress Helpline is very important to know about, and whenever there's a disaster, the SAMHSA headquarters staff sends that out to officials in the state, and I also send that and a compilation of resources to the state authority in charge of mental health and substance use programs. Then there's the National Suicide Prevention Lifeline, which I also talked about already. And there's an email address for our Disaster Technical Assistance Center, which is very simple. It's just dtac@samhsa.hhs.gov. And most importantly, as I said before, samhsa.gov will lead you to all of these things. Next slide, Allison, please. So this is similar to the prior slide, but emphasizes that there's an SMS text option. So I wanted to show that too. And I think depending on what strikes your fancy, you might like the prior slide better, or you might like this one as a standalone resource for you. So I offered that as well. And this also has Spanish and deaf and hard of hearing options. Next slide. One thing that happens after a disaster is that if there's a presidentially declared emergency, there are crisis counseling funds that are made available through grants in a collaboration with FEMA, SAMHSA, and it's divided into a couple of main buckets: the Immediate Services Program and the Regular Services Program. I'm going to show you on the next slide what that looks like. Go ahead, Allison. Oh, I'll do it in two slides. So let me just tell you the principles of the counseling program are that it's strength-based, outreach-oriented, anonymous, conducted in non-traditional settings, culturally competent, designed to strengthen existing community support systems, and flexible. Okay, next slide, please. So this is a little slide that shows the Immediate Services Program bucket that I described in the Regular Services Program. So basically along the bottom, just like I had on the model, the timeline is from the beginning of a disaster until afterwards. And the timelines and sort of process is very, very specific. So there's not a lot of time to put in an application for the Immediate Services Program. It's within 14 days of the disaster. And then after the Immediate Services Program ends, the Regular Services Program kicks in and goes along for about another 9 months. So the main point, though, I think, is that the main point this sort of gives you a heads up about is that SAMHSA is really a grant-making organization, and you may not want to wait until a disaster to look on samhsa.gov or grants.gov to look for grant opportunities for which your community is or organization is eligible. There's lots of grant opportunities, and I encourage everyone who is in an organization that has the capacity to apply for grants, make yourself aware of those on a regular basis. Next slide. So now I will not spend a lot of time on each one of these resources, but I am going to go over a few that are very pertinent for this workshop today. So this one is fairly new. It's a national guideline for behavioral health crisis care and a best practice toolkit. So it talks about crisis services for individuals who are homeless, using technology to improve delivery of behavioral health crisis services, which has been very, very important during COVID, addressing a substance use and behavioral health crisis care companion resource that is in the SAMHSA's crisis toolkit, also includes legal information, financial mental health crisis services, addressing unique needs of diverse populations, and then there's a few others that are listed. So let's go to the next one, please. Get Connected is linking older adults with resources for medication, alcohol, and mental health. So it's really good to be aware that there's technical information and information that is clinical and also can help educate you and educate older adults. Next slide. This is Rhonda talked about tip sheets. I'm going to talk about tip sheets, and what I did was I pulled 4 recent ones that are very applicable across the top. The top 3 are really very much geared for this talk today. So number 1 on the far left is how to cope with sheltering in place. Number 2, taking care of your behavioral health, tips for social distancing, quarantine, and isolation during an infectious disease outbreak. And actually number 4 on the far right, coping with stress during infectious disease outbreaks. Number 3 is tips for caregivers, parents, and teachers during infectious disease outbreaks. That doesn't apply as much, but it may be of interest since I'm sure we have parents and grandparents that might be interested too. Next slide, Allison. This one is helping older adults after disasters. Next slide. That's a quick guide for providing support. These are suicide prevention toolkits on samhsa.gov. SAMHSA is the leading agency on suicide prevention in the federal government. And I have a regional suicide prevention learning collaborative that's been meeting quarterly for many years. If anyone is from my region and interested in joining that, you would be more than welcome. And if you are from another region and you want to know if they have a similar opportunity, you can either email me or when you see the regional administrator map, reach out directly to that regional administrator. So there's a lot of very important information to understand about suicide prevention, and we don't have time to go over it today, but I do want to emphasize that SAMHSA leads when it comes to this topic. Next slide. SAMHSA is really known for taking evidence-based information and translating it into information that is easy to understand. So we have webinars and podcasts that address behavioral health responses to disasters for a variety of audiences. And I really encourage you to take a look at those. And it's all free and downloadable. Next. So the Disaster Technical Assistance Center is always trying to stay ahead of the most recent evidence that's out there, and we're constantly changing and updating our information. So I just wanted to mention that. And next. We had a little, okay, well, we skipped through a couple, no. Yeah, that's fine. We skipped through a couple of those, but missed a couple of resources, and I'm about into my Q&A period. So, so my timer was not the same as yours, Allison. I don't know if you took off a few minutes, but I didn't realize my time was up. But let me just say in conclusion, I hope now you understand the why, when, and how to use DTAC resources on SAMHSA.gov, your critical role, and that you will remember the solution is up to you. You can decrease the worry, trauma, and possible death of your loved ones or the older adult citizens in your community for whom you are responsible by having a plan in place well in advance. So let's continue the conversation, and I hope to hear from a lot of you. So Allison, I didn't have the same timing as you, and I apologize, but I think I still have at least a minute. So yes, you can get a copy of the slides.
Hey, Jean, this is Rhonda. You do still have about 3 minutes.
Oh, okay. All right,
and we
great.
do have a question for you.
Oh, awesome. Great.
So this question is looking for, is there a website for training to use naloxone? I'm taking a class but would like to explore the site.
Okay. So I'm going to challenge the audience to see who is really listening. Does anyone else remember where the naloxone training information is? See if anyone caught that. See how well I did. So the main point that I wanted to really drive home, and I'm really glad that you asked that question, Brenda, is that everything that I talked about, every single resource, is on SAMHSA.gov. There you go, Jim got it, and he spelled it correctly. So on the SAMHSA website, there's information about naloxone, how to get the training, and there's actually an organization you can go to find out where in your local jurisdiction or state to get a dose of naloxone. I know in Philadelphia, that's right, Frank, no shh in SAMHSA. I know that there's a website that you can go to and request naloxone. It'll be sent to you. Really very easy. Rhonda, were you going to say something? I heard a little rustle.
No, I'm sorry about that.
Okay. Indra, thank you for your comments. You know, I think that since we have a minute or two left, I would really encourage questions about specific topics. But, you know, Allison, one slide somehow we missed. I really want to go back to the SAMHSA map. Yeah, there. Okay. So this is the map. So if you just go to SAMHSA.gov and type, or if you even just Google Regional Administrator SAMHSA, all of us will pop up. All of my colleagues and I that are in these positions will pop up, and we all now have, as of about the last 6 months to a year, assistant regional administrators. So we are happy to help you if you have questions, and if you want an email introduction to any of these folks, if you're shy about contacting them directly, just let me know, and I'd be happy to do that. And can you go to the next slide, because I did want to make a couple of the points in these slides. So you know, one of my closing thoughts was everyone has a connection to our workshop topic. On this slide, that's a picture of my dear old dad, rest his soul, on his 90th birthday, and that's my godmother in the pink, and her twin sister in the blue, and we're sort of hugging on each other after I had taken them out for their birthday near Philadelphia. So I think you all have similar relationships with people who need our help, and you know, I do too. So that's why I'm doing this. And next slide, please. And I like to end on an optimistic note. You know, there's a lot of needs out there, and you may wear yourself out sometimes thinking you have to do it all yourself, or that there's too much to do or not enough time. But I think that what you can remember is that with a little planning, we can really take care of the bulk of the needs, and that most people are resilient. Some need some support, and a few actually need a lot of support in clinical services. So, and I think that was my last slide. Go to the next one. Yeah, so that's my contact information. I'm really easy to find. People Google me and find me all the time. And, you know, we have town halls and other events, and we have a number of learning collaboratives. If you're in my region in particular, I'd love to welcome you to those if you're interested. And I'd be interested in hearing what you might have to share about your questions or loved ones that you might have been helping with their mental health and substance use disorders. And I'll put my contact information in the slide, and I really appreciate the chance to present today. Thank you very, very much.
Thank you very much, Jean. Really appreciate it. That was a very powerful presentation. It is now about 2:37, so we are going to take a short break. We will resume at 2:45. Thank you, everybody. Welcome back, everyone. Hope you all were able to get a break there. We have some exciting speakers coming up today. Our next speakers are Greg Olson. Greg is the acting director of the New York State Office for the Aging, and he has almost 30 years of experience in a variety of capacities serving older New Yorkers and their families. And also joining Greg is Becky Preve. Becky is the executive director of the Association on Aging in New York. Prior to joining the association, Becky was director for the Franklin County Office for the Aging. Greg and Becky, take it away.
Well, great. Well, thank you so much, and it's great to be invited back. I want to thank FEMA, ACL, and SAMHSA. Certainly want to thank my counterpart, Becky Preve, who's the association director. And it's nice to be introduced as the next exciting speaker, so I hope that that's the case, and I appreciate the 226 people that appear to have joined us today. So, you know, we've all had a tough year. There's no question about it, and all trying to figure out the best ways we can to meet needs. Many of the items that were talked about today are similar things that we're dealing with, obviously, in New York State. And I don't think that the way that we do things is necessarily the right way. But hard to believe, you know, I've been doing this almost 29 years, and you hope that you evolve over time and understand what works and what doesn't work, how to be the most effective. And so I want to provide a little bit of context before we dive in, because I think context is really important. But before I do that, I would like you all, regardless of where you are in the country, to help me recognize our regional administrator, Kathleen Oddie, who received a well-warranted award last Friday from the state of New York for her amazing contribution, not only to our state and to our office, but certainly during the last year under COVID, has just been a real important partner for us in order to get the work done that we needed to get done. So again, Kathleen, congratulations to you. So the way that we look at aging in New York State is through a different type of lens. And you may wonder, you know, why are people who are delivering social services kind of approaching aging through a more economic lens? And the simple reason being that, you know, we have an opportunity, because it's a real life situation, that older people bring value. If you grow up in the culture of the United States, we're in an ageist society, stereotypes, generalizations that older adults are not valued, they're takers, they're not givers, and none of that's the case. And what I found over my almost 30 years is when you come in with anecdotes and don't have data to back it up, you don't get the results that you want. So about a decade ago, we really started to look at putting data behind establishing the value of what older New Yorkers mean to New York. And this is going to be no different than what they mean to your states as well. And we've been able to do that very, very effectively. that has led to tens of millions, actually a $45 million investment in my agency over the last 3 years. And we are finishing up our budget cycle as we speak, and could be seeing anywhere between another $27 and $37 million to help meet the needs across New York State, because we've been able to develop that value proposition. And we think that that's really important. The second thing is to demonstrate the value of this network. Again, I used to work in the state legislature. They thought of the aging network as trips and bingo or as home-delivered meals, and certainly that's a part of it, but that is far from what we do and how important we are, you know, for healthcare, for families, for the regional economy, for service delivery. We can't deliver services without the older people who we rely on, many older adults in the workforce, and so on and so forth. So really creating those two types of value propositions. In the world of emergency management, that's been critical. Over the last 10, 15 years in New York, we've had a variety of disasters. We are now part of our state's disaster preparedness plan with many of the other state agencies, and at the local level, all the county offices for the aging are part of their emergency operations center and part of that county infrastructure, so that when we have things like floods and hurricanes, unfortunately, and winter storms and things like that, we can respond using all the assets that we have at the county level and at the state level. During the pandemic, I think we have more than proven our value, both at the local level and at the state level, in every facet possible. So I think that there's a lot of really good things to talk about, but wanted to set that context. So I know you'll have these slides available to you. I'm going to kind of run through them quickly. But again, going through, I never do a presentation without talking about the value of the population that we serve. And when you're in the aging field or you're in the health field, we're almost our worst enemies, because we see the people who are the most frail, the most complex, that have the most needs. But we shouldn't be painting the older population with a broad brush, and we can't do that. So in New York, we have the fourth highest number of older adults, 4.6 million. Our next set of older adults, we have 3.7 million between 45 and 59. That means almost half of the state of New York is over 45. We have almost 1 million volunteers that we rely on every day, but so do so many other community organizations, whether they be in healthcare, whether they be in mentoring and education, you know, county level. I mean, there's so many different things that older people do that contribute almost 500 million hours of service every year at an economic value of $13.8 billion. We would not be able to provide transportation, home-delivered meals, high cap, our long-term care ombudsman program, and many of the other things around food service and other services without our volunteers, and so would many other sectors who do that. We have a very large proportion of older adults that own their own homes. Why does that matter? Well, they're sitting on a mountain of home equity that could be used to help them stay in their home, but more importantly, they're providing resources to county governments. They're supporting Medicaid. They're supporting schools. They're supporting local businesses. We've been able to aggregate all of that. And then, of course, everybody is well-versed on the caregiver burden, who they are, and when you pull that role out of caregivers, how much that would cost. And in New York State, that would be a $32 billion hit on the Medicaid program. So a very, very important population. We also aggregated all the household income generated in New York State, and not surprisingly, if you look at these two slides, I understand that they're small, but over a 10-year period, 65% of all the household income generated in New York is the 45 plus, and it amounts to about $481 billion a year. I presented our data, and I have lots more. This is just a snapshot. To the AARP about 7, 8, 9 years ago. They came out with the 50-plus longevity economy. The whole conversation is need to get on board to help us combat ageism and stereotypes and really put value on this population, because they matter. They matter to the community. They matter to the county, the regional economy, the state economy, the national economy. And when you value something, your interventions are very, very different than when you devalue or disvalue somebody. But what they showed, again, backs up much of what we put forth for our 60-plus population. 83% of all the wealth in the nation is held by those over the age of 50. They are huge contributors to the federal, state, and local tax coffers. They are the #1 group of volunteers, #1 group who gives to philanthropy. They're the #1 entrepreneur block. They're the #1 group that provides donations. They spend more money than their younger counterparts in many, many areas. They support almost 90 million jobs, and we know that many of them are in the labor force and will continue to be in the labor force. So this isn't what we all grew up with, old, frail, Alzheimer's, people in nursing homes. Of course, we do have folks like that, but that's not who the older population is. And when we present to governor, the legislature, the county executives, or private businesses and are able to back up our data or what we're talking about with data, that has led to very, very positive results. Becky?
Thanks, Greg, and thanks to everyone for hosting this. And I think, my takeaway always when we look at the demographics of the older population and their contributions really sets the stage for what we're going to talk about. So I wanted to go over briefly New York State trends and demographics. I don't think this is going to be a surprise to anyone. Family structures have absolutely changed, and we're seeing, less and less married couples with children. We're seeing more single-parent households, and that really drives us moving forward, kind of looking at our aging services infrastructure and supports. Next slide, Greg. One thing we wanted to really target is health and impairment of older adults. Again, this is not going to be a surprise to many of you. Obviously, we deal a lot with chronic conditions, and they are the major cause of illness, disability, and death in the U.S. If you look at this chart, the 65 and over, you can see that 35% of them actually have some sort of disability. Of note, Greg and I were actually on a call this morning looking at our data, and we have a large number of customers with 10 or more deficits in the ADLs and IADLs, so it's definitely something that we're looking at, treating much sicker individuals in the community for much longer periods of time. And here you can see the estimated cost of chronic conditions reaching over $864 billion by 2040. So it's something that we're definitely kind of laser focused on to make sure we're able to support in the community. I wanted to talk a little bit of our network infrastructure, and again, this is similar across states, but New York is unique, and we have 59 county-based area agencies on aging, so we have a large number of them. They work with about 1,200 subcontractors, and you can see here we have a very robust service delivery system, including the largest nutrition program in the country pre-COVID. We've actually seen a 70 to 90% increase in nutrition concerns throughout the pandemic, so we continue to be in that playing field. We also really touch the healthcare system in our evidence-based programs that we have over 41 of the highest level of those, as well as what Greg spoke about as far as our robust volunteer network and service. Some of the things that I wanted to just touch base on, because a lot of people aren't as well versed in the programs outside of nutrition that are actually hosted through area agencies on aging. We also provide nutrition counseling and education, senior center programs, health promotion activities, a very robust respite and caregiver support program. We also provide legal services, home modifications where we can install handicap accessible bathrooms. We also run a very robust elder abuse prevention and mitigation program. New York State is also a member of the New York Connect system, which is the no wrong door single point of entry for any and all services throughout the lifespan. We also have a objective health insurance information and counseling program, which allows people to really access the appropriate Medicare plan or other health plans in their communities. We also provide personal care services for people that don't qualify for Medicaid, so hands-on in-the-home care, case management, our ancillary services, including personal emergency response systems, social adult day transportation, and the long-term care ombudsman program.
These are well-established nursing home risk indicators, and why do we talk about them? Because we do a lot of work with health systems, primary care practices, really trying to bring much closer together the clinical systems and those that address social determinants of health, which we do well. But these are what determine somebody's risk of a higher level of care, whether it be in a nursing home or moving into, Medicaid, community Medicaid, or managed long-term care. And just to give you a snapshot, we have 5 core services that we require people to do a comprehensive assessment on, and our assessment is quite comprehensive. Becky will talk about that in a second. But our average customer is an 83-year-old female who lives alone, who's low income, has 4 or more chronic conditions, 2 ADL limitations, and 6 IADL limitations, who's at nutritional risk. And we know that we're able to serve these individuals for about $7,000 a year who would otherwise wind up going into a higher level of care. And we did a deep dive on our clients on waiting lists to know exactly what happens to people that we're able to serve them for upwards of 7 years with the vast array of support services and cross-systems work that we do with other county departments, community-based organizations, and many of the partners that we've been able to establish over time. If you look at this just shows those 5 core services, and the overwhelming majority, 70% or more in all 5 of these services, PC1 and 2, home delivered meals, adult day, and case management, have 4 or more chronic conditions. As Becky mentioned, we were delving into some specific data this morning, and I saw a bunch of customers that had more than 10 chronic conditions. And if you don't manage those or recognize what they are and connect folks to ways to help improve those or at least maintain them, the outcomes are not going to be good. This is a really small slide. I'm not going to go through it. You'll have access to these, but these break down what those chronic conditions are. Not surprisingly, it's things like arthritis and COPD and hypertension, diabetes, those things that, again, the health systems are really interested in helping to partner so that they can reduce their expenses, improve their outcomes and their HEDIS scores, and we can be great partners with them in order to do that and help diversify our funding streams and increase our capacity in service delivery.
And just to tie into really what the AAA and the aging service provider strengths are, and this is across the country, and it's really why we can absolutely assist in disaster preparedness as well as reaching the really hard to serve customers just based on the work that we already do. So we're already established. We have an infrastructure and a network. Again, New York State contracts with over 1,200 subcontractors that specialize in the vulnerable population. There is a wide knowledge of all community-based providers and networks that are available and how to access them. This really dives into that local community response because we know who to contact. We also are very well adept at hospital care transitions and evidence-based programs. We have a very robust, highly trained network. We can also work with the community overall to not only assess varied needs but also address them. And we have established relationships and trust with medical providers, with social services providers, with community-based organizations. And the one thing about our network is we're in the home. So we're eyes and ears in the home, in the community, and that information is very beneficial for all service providers. We're also not episodic. And so when I talk about episodic, many of you are aware that you can get an acute care referral for home care services. Or your insurance company may provide short-lived service. We aren't episodic focused and we're not insurance driven. So we can serve patients for life. We can work with their whole families as an individual, and we can work across all care settings. So it doesn't matter if you're in your home and community or if you're in an institutional setting, we can still serve you. Again, we're really the eyes and the ears of the medical professionals in the home. I can tell you prior to my work in aging, I was a hospital discharge planner, and some of the first calls that I would make when a client came in that was on service was to the local AAA to find out what was really going on in the home and community. We're really focused as being the best value to improve the health of the community and people at large. And I think Greg mentioned this. We serve people much cheaper than many other systems are actually able to do so. And so it's a service that allows people to remain in their homes and communities at a much lower price tag with much better holistic care than other service models.
Right, so why are we talking about all this? Because there's way too much work to go around. This is a time and has always been a time where we shouldn't be turf-oriented. We need partnerships. We need connections. They need to be public and private so that we can really meet people where they are, be person-centered, make sure that people aren't falling through the gaps. This is just some of the data that we collect in our comprehensive assessment. Now, if you're on the healthcare side, think of how valuable this data is, just the personal information and not to be duplicated if we can have an electronic interchange, living arrangement, elder abuse and neglect, are they frail, disabled, what's the caregiving status, what are their housing situation. We do a home safety checklist, we do an energy checklist, we look at social isolation and added a social isolation scale. We look at neighborhood safety, do you have pets? That matters in emergencies. How about your self-evacuation ability? Do you need assistance? Medical treatment, emergency accommodations, your health status, medical insurance, chronic illness or disability. Do you have assistive devices? When were your last health care visits for everything from hearing to your primary care physician? Have you had a UAS assessment for your PRI score for nursing home placement? Advanced directives, your body mass index and nutrition screening. Psychosocial status, we screen for depression, anxiety, alcohol and substance abuse. As I mentioned, we put in a loneliness isolation scale. We added a tech check so that those that can be connected immediately to technology platforms can. Others we could work with or figure out different ways. We know what your medications are. Do you have a fall risk history? IADL, ADL history, what services they're receiving, whether there's informal supports, again, looking at assets, not always deficits, income, connection to veterans, and then we serve folks by getting them the benefits that they need. For example, we helped put $95 million into the pockets of low-income Medicare individuals last year through the MSP, QI1, low-income subsidy, et cetera. So again, this is gold for, an interchange between acute care and community to assure good discharge planning so that, if somebody enters an emergency room or a hospital, this data is available to individuals and it's on a two-way street.
And just to go into a little bit further example of what that actually looks like, I'm going to walk through some successful discharge planning activities, emergency room diversions, reductions in social admissions, patient satisfaction in our partnerships, as well as the community interventions that we're using to really address social determinants of health, which are so very important currently. So the interventions that we're able to provide through our very amazing network really allows for support in the community. It's low cost, it's high yield. We're able to ensure individuals are able to age in place. As Greg mentioned, we actually did a deep dive of people that were placed on our waiting list and found that 10% went directly to a skilled nursing facility. There was no intermediate care, really showing the value of being able to turn our services on. All of our interventions are really focused on improving healthcare outcomes, which is so important, and really to enhance medical interventions to make sure people are successful in their communities. I want to talk about successful discharge planning because I think this is very important to make sure that the clinical and non-clinical services are really melded together. And it's something that healthcare has been focused on throughout the past decade or so and is really going to be focused on moving forward. So again, if you are able to wrap services around somebody, including transportation, home-delivered meals, PERS, and really be able to meet with the family and the community, you can really change the outcome from a hospital standpoint. And so this is actually a real-life example that I had when I was a clinical social worker. Very common issue with heart disease and kidney failure, that they're very medically complex and frail. Numerous admissions over a 6-month period. There was no primary caregiver, a lot of denial about the disease progression and prognosis. And through working with the AAA and case management, we were able to develop rapport in the community, put in services, were able to make some contacts with out-of-state relatives, and wrap around other services and supports that ended up allowing this individual to remain out of the hospital in his home and utilizing hospice services. So again, I wouldn't have been able to facilitate that just from the hospital standpoint. That was a community-based intervention as well. Something else that we really looked at were emergency department deferrals. Obviously, people going to the emergency department is not where people want to go. And it's very crisis-oriented, and with the changes in Medicare, many people are told at the hospital, you're a social admission, you don't belong here, this isn't going to be paid by your insurance. And it's a very crisis-driven instance for the individual with typically poor outcomes. So what we looked at is to really be able to work with 911 dispatch staff to make sure that we were educating and referring appropriately. And this was really a wonderful example we were able to do in upstate New York, where all of the 911 dispatch staff were trained on the services available through community-based organizations. And so if someone called in crisis, they would be screened to see if they actually needed a rescue squad or state police to attend, or if someone was having caregiver breakdown or had a social issue like I ran out of fuel oil or my phone got disconnected. And if the client was agreeable, then we would be triaged through the AAA instead of sending out those valuable resources. The other thing that we were able to do, which really tied into emergency planning and was actually implemented during some flooding in northern New York, was we were able to upload all of our client data into the 911 system. So if one of our clients that we were serving called 911, the screen would show up in real time that it was a AAA client, that their spare key may be underneath a rock outside the door, that there's a cognitive impairment and they have a large dog. All of that information was readily available for that 911 dispatch staff to actually screen and see. So again, we had so many examples where this really was utilized a great deal to make sure that we weren't wasting valuable resources for instances that shouldn't have happened. And I will just speak very briefly, this communication with our EMS system and 911 dispatch staff during a massive flood that we had. We actually had a client who was an older resident who had animals who wouldn't vacate her home even though it was flooded and it was going to be 20 below that evening. And instead of, an aggressive, either having her pulled out by rescue or by the state police, I was able to be contacted. We did a joint visit together. They allowed me to enter her home and to be able to talk her out to come with us to make sure that she was safe. So it was a great intervention on behalf of the client. Talking about social admissions, again, this is really important from a global standpoint, that there is a lot of misunderstanding in the community about Medicare, what's covered under Medicare services, and many times hospitals, really have difficulty in communicating with individuals what insurance does and does not cover. We're trusted. We're in the community. They believe us when we're talking about information. We're also well-versed in what community interventions may be available, whether that be, looking at a different insurance plan or a Medicaid waiver program. Those are all things we're able to do in homes and communities outside of that kind of four walls of a clinical setting. And again, we can be contacted directly from emergency departments to talk about interventions, durable medical equipment, all of those things that sometimes are really hard to get on behalf of individuals. And we can really reinforce, hospital criteria, what the process is, and how to appropriately gather and get services. Again, patient satisfaction, it's something that all hospital systems and long-term care facilities are gauged on. It's really important to hospitals and their payment structures. We're actually able to really partner in the community to make sure people are educated, and this reflects in patient satisfaction on the acute care side. So again, to have a partner that can reinforce the understanding of diagnosis, treatment, and follow-up services, as well as disaster planning, fits directly into this. If we're able to facilitate those conversations prior to crisis, you're going to have a better overall outcome. And again, we're able to act as patient advocates throughout the home care and hospital experience, which is really important to the families that we serve.
Okay, so I just want to warn Becky, we have 20 minutes, so we're going to pick up the pace a little bit. So we created the value of the population. I think we've more than created the value of what the network does in a variety of different ways, from emergency to community partnerships and what we bring to the table. So I'm going to kind of zip on through some of this because it's the same types of things that you guys have been dealing with. We have from the get-go, obviously COVID hit New York really hard, really early. We are still dealing with, 1 year later, misinformation that this is no different than the flu, the masks don't work, it's a hoax. It's really hard to believe with over 500,000 people dead that we're still dealing with that. Now we're dealing with the anti-vaxxers, people that don't want to get the vaccine. But this has been, unfortunately, extremely political at the detriment of the country, at the detriment of the state, at the detriment of our families, and certainly for our coworkers, friends, families, volunteers who have died from the virus. We launched a COVID-19 checkup. I think we're doing a presentation for some of the ACL regions in the next couple of weeks. Have done a few. This is the only tool in the country that actually assesses your risk for contracting, spreading, being hospitalized, and dying from the virus. We are not out of the woods yet, and so staying safe until we are at the 80% vaccination rate is critically important. So I urge folks to check out that resource. It's available for free for any state in the country. We New Yorkified ours, so it's a little bit different. Obviously, the vaccination effort right now is job number one, in addition to some of the things that have been talked about before. Our 6 primary things that we've been doing for over a year now is home delivery. We, as Becky said, we have the largest nutrition program in the country. We served over 30 million meals so far during COVID. It was about a 75 to 100% increase. Heard earlier in the beginning, grocery and supplies. People still don't want to go to the grocery store, but in the beginning in New York, people were told to stay home, so they couldn't go to the grocery store. So the grocery and supply delivery went up. Medication deliveries became critical. Transporting, cancer treatments and dialysis don't go away in a pandemic, so we had to ramp up the transportation of those critical types of services. Everybody's dealing with combating social isolation, and we'll get into some of the innovative things that we've put on the table and implemented in New York. And then, as was mentioned earlier, the elder abuse and scams was always a problem that has gone exponentially up since COVID, particularly on the elder abuse and the scam front. Very, very sophisticated stuff, but it's still the overwhelming number of scams are things associated with text messages, phone calls, and emails, things that you don't have to answer and you don't have to click the link. We did a lot with our flexibility at the federal level, and then the governor followed up with flexibility in our state regulations to just tell the counties, do what you need to do to provide services. Don't let the bureaucracy get in the way. We're not going to come in after with some punitive measures that say you should have done X, Y, Z. No, the charge was do what you have to do, and that's going to be different in Niagara Falls than it is going to be in New York City to up on the Canadian border, and that's not my decision to make. That's Becky and her members because they know their community and know what the needs are. We were instrumental in getting over 1.875 million masks, not only secured within my agency, but delivered to all 59 AAAs. We delivered more than 3,200 cases of hand sanitizer. Becky and I delivered them to 14 counties personally. We rented a truck just to say thank you, to say, you know, keep it up. You're doing a great job. We support you. And we've done a lot on social isolation. We'll talk a little bit more about that in a second because this is kind of redundant. So we call this organic projects, but it really isn't. These are the innovations that we've been able to put forth. I get a lot of calls from other states who are interested in what we were doing and how we were doing it and say, well, how did you do this or what funding did you use? And what I always come back with is the Older Americans Act and our state funding has always given us broad flexibility to do a lot of things. There's not much in the Older Americans Act that we all aren't dealing with one way or another, and we do have that flexibility. And then when you have these disaster declarations, both at the state and local level, you have that much more flexibility to identify new priorities. So if we're spending $100 million, for example, which we were actually quite a bit more, on congregate meal infrastructure, and we close down 820 congregate centers, that frees up dollars to be able to reprioritize and redo. So we'll start with the business acumen. We became the first state in the country to really look at this, how we connect the health systems and the clinical environment with our network addressing social determinants of health, and have developed a 2-year project, and we're well on our way. But I think what we learned through COVID is we had to put a lot of things on hold, but the value of what this network does clearly is recognized at the federal level through the first couple of stimulus package, right through to the American Rescue Plan, that this network has a great value. The health industry within the state has recognized the same thing because we were there to provide those basic services and to make sure that there wasn't an increase in hospital capacity or emergency room visits, et cetera, et cetera. So it gave Becky and I an opportunity to really retool that, and we're in the process of implementing 7 or 8 different pilots with different health systems or hospital systems or primary care practices to get our folks paid for the work that they did, to bring the things that we do well together to match up with what the clinical community does well together so that we can serve people from a person-centered, holistic way and not have them fall through the cracks. Executive Order 190 was something that we had, that the governor had signed that builds age-friendly, livable community principles into how state government works, both in policy but most importantly in procurement. We had put out a grant to give money to counties to basically replicate Executive Order 190 at the county level. We have 7 counties doing that now, in addition to about 40 of them that are going through age-friendly work on behalf of the World Health Organization, AARP. We plan on providing additional funding to bring another 10 counties on to replicate, because what's included in all of that? Caregiving support. The design of communities, transportation options, housing options, civic engagement, social isolation, access to services and healthcare, and so on and so forth. The VTAC and the village movement, some folks see that as in competition of what we do. If there are any communities that want to help organize themselves to help their older residents, whether it be shopping assistance or transportation or any other tasks that help them remain independent, we're going to support that. So we stood up and funded the first Village Technical Assistance Center in the Capital District, which really takes a community from A to Z, from the idea to the actual implementation, and we seeded about 7 programs so that they can build their own village movements, which again takes pressure off the County Office for the Aging, takes pressure off of my agency to provide funding. We can provide support, and we're going to continue to expand those across the state. I was also a big fan of the Home Share Vermont program. I don't know if they're on the phone. Becky and I visited them a couple of years ago because we wanted to see if we could replicate that program. And Woodstock, I think that's a name everybody knows here in New York, is ready to move ahead. And so we're going to be replicating the Home Share Vermont program with, in Woodstock, New York. Why is that important? Again, after you get through the screenings and the matching, this is a really great way for individuals, both economically, somebody who needs a place to stay, but also an older adult who might, need some additional revenue, to have somebody there. What we found is many of them got into these relationships for an economic reason, but after a year, all of them were doing basic tasks, PC1 tasks, shoveling snow, grocery shopping, helping out, combating social isolation. So I'm a big fan of that type of pilot projects, see if we can replicate those.
So GoGo Grandparent is also listed here. GoGo Grandparent is actually a California-based company that we were able to pull into New York State because of the mass transportation problems that we were seeing. So it's an Uber and Lyft type of model, but it matches individuals who are comfortable transporting people that may have a mobility issue or may have a cognitive impairment, and is really an amazing company we were able to bring to New York State. I'm also going to talk a little bit about unmet need funding. This is something that we found amazingly beneficial to the state of New York, and really was able to drive that investment Greg spoke to about the $45 million over the past 3 years. That money is directed towards the actual documented unmet need. And when we talk about unmet need, any of you that run a AAA know that you have a set number of dollars for a set number of services. And if you have people that are looking for service that you can't afford, many times they're turned away or waitlisted. So what we were able to do is really take that waitlist unmet need data in New York State. We were able to aggregate how many of those individuals went to higher levels of care. Again, it was 10% went directly to a skilled nursing facility, an additional 6% spent down to Medicaid or MLTC plans. And what we did is we booked the cost of turning those services on against a future Medicaid savings. And so we were successful in the executive budget for the past 3 years. This year we've done the same thing with our unmet need or waitlist information, and we were able to book what potentially could be a $27 million addition to our service structure against over $60 million in Medicaid savings. And what it allows us to do based on an unmet need formula is instead of those funds flowing through the traditional census data information, it is targeted to the actual counties that have the need, which has been unbelievable as far as our flexibility and has been very imperative as far as us making the case that an investment in our services saves the healthcare community and the Medicaid community massive amounts of money.
Becky, I'm going to run through these quick. We got 9:30 to go. I'll have you do the pet project. I'm just going to mention these, and anybody can get back to either of us afterwards. We became the first state in the country a couple of years ago after a 3-year lobbying effort on my behalf to be able to compete in the marketplace. We have a lot of older adults that have resources. We have a lot of people like me that have parents that have resources that could buy services through the AAA, but we were statutorily unauthorized to do that. So we got that statutory authorization, and we are entering the private pay market because what we bring, we're not selling a product, we're selling independence, and we're selling information and not in an objective way. We are working on a significant expansion for nutrition access under the FEMA opportunity. Becky and I brought to 12 counties a partnership with the New York State Council on the Arts and Lifetime Arts, programming into the homes of older adults. We launched 2 weeks ago in 10 counties a virtual senior center model that is going to provide virtual programming 24/7 to individuals in 10 counties. We're about ready to launch a project with a California company called Get Set Up. We're buying 50,000 classes. They have 150 different types of classes on things that make people tick. Do you like to cook? Do you like to do photography? Do you like to go to the opera? Things like that, again, so that we can combat social isolation. I mentioned we added a tech assessment to our comprehensive assessment, so we already know who can access these types of things and who can't. We're going to expand our stipend program. We did this for our long-term care ombudsman program and our SHIP program, which is high cap, so that we can encourage and help retain volunteers. what we found is that by, offering a $600 a year stipend, that was enough to significantly increase the hours of volunteerism. And then I mentioned the COVID checkup. Becky can talk about what I like to call our award-winning animatronic pet project.
Thanks, Greg. And so this is actually a feel-good topic, and everybody likes to end on a good note, right? So I'm going to give Greg lots of kudos here. As I mentioned earlier, prior to running the association for the 59 AAAs, I actually ran a local AAA, and Greg from the state approached all of the counties a couple years back and said, I want to launch this project with animatronic pets. These are cats and dogs that are very lifelike. If you have a hearing impairment or a cognitive impairment, you can actually feel the cat purr, you can hear the dog bark and hear his heartbeat. And the project was born because one of Greg's daughters actually brought one of these animals home, and he said this would be great to expand. So super long story short, we were able to pilot these pets in numerous counties throughout New York State, but we tied it in with a loneliness and isolation scale. So it's a 6-question questionnaire that measures how you're feeling as far as being isolated or lonely. And then we redid the same survey 3, 6, and 12 months after adoption of these pets. And we saw a 70% reduction in feelings of isolation and loneliness. And, this was something that was identified as a public health pandemic prior to COVID. Through COVID, we have seen this explode. And so working in partnership with Greg, and surveying the counties to see what the interest was, over 4,000 of these pets have been purchased and distributed throughout New York State, with an overwhelming response of this being a life-changing addition to individuals' lives. It's gotten numerous national press attention, and it's really just been an amazing project to see, and really drove us to actually look at social isolation and loneliness when we do our comprehensive assessments, and it's now built into our assessment structure. So it's been an amazing program that we're really proud of here in New York State that I would highly suggest people look into in their own communities.
Yeah, we were able to negotiate a code so that anybody could buy them at a discount, but many other state agencies are utilizing them, federally qualified health centers and folks around the state, and we're getting ready to purchase another 1,100 more. Okay, so I want to just quickly move to this. I see in the chat there's tons of really good questions that we can help clarify, but again, been doing this for 29 years. The Older Americans Act has a lot of flexibility in it for us to do our jobs. But what I've noticed over time, and many of you probably have too if you work within this structure, is there's a lot of pieces to it that are very antiquated as well. And what better time to make changes than in a change-making time? The president wants to build back better. The governor wants to build back better. We've been able to identify, both pre-COVID, but certainly through COVID, the things that need to change. And one of the things that I've noticed, again, is the Older Americans Act gets amended every so often. There's a whole bunch of new things that I'm required to do as a state unit director, and then I have to pass down to Becky and her members that come with no resources and come with more work. And it's time to, I think, address not only some of those things that can be updated, but I think we have more than proven not only our value as a network, but in order to continue to help people remain in their community, they're going to keep those volunteers, and they're going to keep their money spending, and they're going to continue to support local businesses and the taxes, et cetera, that keep our nation in good economic shape. I'm more than happy to send you details on this as a high-level overview. I'll put my email address in the chat afterwards. But this is a little bit of structure. If you look at the triangle on the left, we receive the least amount of money from the federal government. We receive about $170 million commitment from the state, and then the counties put in almost $300 million, and we get about $77 million from the federal government. The middle triangle is what the House markup was that wound up being the final version of the Biden plan. So that's great news. That'll be another $85 million for New York and some aid coming to you as well. But what we really need for New York, and I reverse engineered this, is about $2.7 billion, not one-time stimulus fund, but an ongoing appropriation that's going to assist you the same way it's going to assist me in meeting the new challenges, meeting a new 21st century look of what the aging network does, how it should be supported, and the tools that we need in order to get the job done. So those are things about updating some of the antiquated natures of the Act, responding to the issues identified by the pandemic, continuing to ensure the flexibility at the grassroots. Again, through the disaster declaration, the counties have, as long as they can tell us how they're spending their money, what they're spending it on, and who they're spending it for. I should not be dictating to them what their needs are. They know it better than anybody, and then position us for the future. And so that's going to require some statutory and regulatory changes. It's going to require some investments, and it's going to, most importantly, need a workforce investment. I love our volunteers, but how can we pretend that we are at the caliber level that we are, having to interact with nurses and doctors and OTs and health systems, other community-based organizations, and have to rely on volunteers as our main deliverers of service? That doesn't make any sense. And that's 1965. That is not 2021. So what we're looking to do is eliminate the match. We've done that in New York State. We had a maintenance of effort up to a certain point, but the counties and the states are struggling right now. And so, you know, we can have a maintenance of effort up to this point. We want to eliminate the transfer language between the titles. That doesn't make any sense. If I have $100 in my home delivered meal and $100 in congregate, and I can't spend the congregate, I can only transfer a little bit. That really handcuffs the counties to meet the need. We want to change the eligibility criteria and caregiver support to 50 and over, be able to address early on-site Alzheimer's regardless of age, continue the flexibilities that we've gotten under the disaster declaration, and things of that nature. And I'm sorry I'm going quick. I got 1:11 left. Investments, we're looking at $2.7 billion. That would bring about $180 to my office in New York State. We need an overall investment to reduce waiting lists, enhance the home care rate to address the home care crisis, provide additional transportation, combat social isolation, expand social model adult day for working caregivers, expand our whole health and wellness and Title III-D business. We need to invest in sustainable nutrition. The nutrition needs are not going to go away. The workforce investment that I mentioned, addressing early on-site Alzheimer's disease, moving grant programs that have proven to be effective into annual appropriations, like lifespan respite, investments in technology, increased funding for the SHIP programs, funding for the first time the ADRCs. You know, it doesn't make sense to have something that has a track record that is effective that all of us are competing on for very, very small amounts of money when we know that they work. Our ADRC, we were fortunate enough to build that is now funded at $27 million a year, but it's under the global Medicaid cap. And so when you have, you know, Medicaid pressures to reduce budgets, that puts our ADRC at risk because it's in another agency. So these are just some of the things that we are pushing. We have spoken with Senator Gillibrand and Senator Schumer. Senator Gillibrand is going to cover both, you know, some legislation to move this out. I would love to have your support. I'm sure there's many, many more ideas out there than what I've come up with, but these are just the things that, you know, I've noticed, that Becky has noticed, that some of the things that have been brought back to us during the last year and then certainly over the courses of our career. So I very much appreciate the opportunity yet again to be here with you today and just share what we've been doing here in New York.
Greg and Becky, thank you so much for another jam-packed presentation today. New York is such an innovator and a leader, and I also especially like that you're not afraid to just replicate ideas you hear of in other places. We did receive several questions during your presentation, but we will have a Q&A following our next presentation, so we'll take up as many of those as we can. I do want to jump on to, I should say Victoria jump, our next presenter. I didn't mean to make that little pun there. Victoria is the director of the Ventura County Area Agency on Aging. She has been with the County of Ventura for over 19 years, and Victoria will bring another interesting perspective. She's obviously out in California, and she will be able to speak about the experiences on the West Coast with disasters. Victoria, I turn it over to you.
Thank you, Kathleen, and greetings to everyone. Thanks to Rhonda, Kathleen, Dr. Bennett, Becky, and Greg for all that you do and for all of the great information. And as always, I will steal some of Becky and Greg's ideas and bring them to California. So I will be drawing from some of the experiences Ventura County residents have had over the last few years through events that have threatened the safety and well-being of the most vulnerable populations that live in our area. These events have taught us a great deal about the ever-changing landscape of what it means to serve older adults and people with disabilities, and really how we can better prepare for future disasters and emergencies, since they always seem to pop up all the time now. Next slide, please. So Ventura County, for those of you who don't know, rests on the coast of California between Los Angeles and Santa Barbara counties. So we are a mix of urban, suburban, rural areas with a total population of over 870,000 people. Currently, about 204,000 of those residents are over the age of 60. The biggest threats currently facing our residents are wildfires, earthquakes, loss of electricity, and the COVID crisis. We found that the most difficult part of preparing for natural disasters, even public health emergencies, is that they can happen at any time, making a response plan and the time that it takes to implement it even more vital. So I'll talk about some of these. So all of Ventura County experiences something called the Santa Ana winds, which are hot winds that blow in from the desert. They generally occur in the fall and winter months, and they can be very powerful and very hot, that serve as the fuel for the fast spread of any fire. They also serve as the primary cause for unexpected power outages and public safety power shutoffs, which can be dangerous for people with life-sustaining medical equipment, limited mobility, and minimal access to transportation should they need to evacuate quickly. These public safety power shutoffs, otherwise known as PSPSs, occur when our utility company determines that the likelihood of a power line starting a fire is really high. So they'll de-energize the lines to prevent the fire, but the loss of electricity impacts those with life-sustaining medical equipment. We also have earthquakes. So earthquakes, although relatively sparse in occurrences in our county, they do pose a large threat to Ventura County residents. The San Andreas Fault runs through approximately 800 miles of California, but we also have our own Ventura Fault, which starts off of our coast and runs through the county. So the California Geological Survey researchers have reported that the fault that we are on is capable of an 8.0 magnitude earthquake, along with the tsunami that would affect Santa Barbara, Ventura, and Santa Monica. Since most of our county is on, is near or on the Pacific coastline, we would have a couple 100,000 residents that would be in the path of this tsunami that we'd have to evacuate quickly. So the COVID crisis has also proven to take its toll on, like everyone, but especially older adults and people with disabilities who have been identified as those at the greatest risk. And I will discuss our county's response to this a bit later in the presentation. Next slide, please. So the emergency situations mentioned in the previous slide pose a huge threat to the safety and well-being of any individual, but they're particularly dangerous for older adults and people with disabilities. Among the most challenging obstacles are navigating, urgent evacuations, people having limited access to transportation, the loss of use or access to medical equipment and medications, the increased risk of falls or other potentially fatal injuries, the isolation and depression, which has been proven to be a major factor as we combat COVID-19, decreased access to food and supplies, and the added risk of elder abuse and neglect. So as an agency, we do have a continuity of operations plan, which was mentioned earlier today, the importance of having one. And we also practice regular drills with our staff. We review our plan every 6 months, and we make updates as needed. And we found that this has really enabled us to quickly respond and activate our plan within hours of any disaster occurring. Next slide, please. So the Thomas Fire ignited in December 2017 in Santa Paula, which is a small community located 10 miles east of the coast. So we had these hot winds that were gusting up to 60 miles an hour for days. And once the fire started, it made the battle to stop the fire impossible. The fire burned through the hills and mountains on the west end of the county and into Santa Barbara County, with final containment coming almost a month after it initially started. Over 281,000 acres were burned, more than 1,000 structures were destroyed, and many of them people's homes. There were a total of 23 fatalities. Many of the homes lost were owned by older adults who didn't have homeowners insurance any longer, as they paid off their homes years before, and they didn't really think that there was any need for having the insurance. For those who were not in the path of the fire, they were still at risk due to the unhealthy air quality, which lingered for months. During the event, some of our communities lost all power and communications, including cell phones and landlines, making critical evacuations a Herculean effort. I think we all assume that if there's a disaster, we'll have electricity or we can have access to our cell phones and landlines, and that does not always happen. So when the rain finally came to the county a month later, this created, a condition that was perfect for mudslides. And the most devastating happened in nearby Montecito, just outside of Santa Barbara County, where 23 people were killed, and we had a major highway that was closed for nearly 2 weeks while they cleaned up all of the mud. In the last 3 years, we have had 6 major wildfires in our county alone. So our county's response to our wildfires has been great. So prior to this, we had some county planning, but it wasn't a lot of coordination. And so in response to the Thomas fire, they set up local assistance centers throughout the county where people could come to one stop, get resources, food, shelter. We figured out that we did a pretty poor job of communicating with the public, and so there's a lot of effort to do enhanced communications so that everybody had the most up-to-date information about the fires and where to go for, the various federal agencies that were there and resources that people could avail themselves. The county also created a website, VenturaCountyRecovers.org, as a way for everybody to go to one place to get all of the information. And this website is still in existence today. They're using it for a lot of the COVID information as well. And so the community has been trained that this is where you go. So one of the biggest lessons from this is that we really we know that we need to ensure that all communication efforts for older adults and people with disabilities, we need to make sure that they're reaching these individuals. We can't assume that that a flyer that's going to go out is automatically going to go to everybody, or a radio announcement. So we need to use all of our, all of the tools that we can. We have personally, as an agency, focused all of our communication campaigns to make sure that they include online, paper-based, telephone, and in-person connections. We're working to make sure our clients receive hard copies of flyers and informational tools, but our staff is connecting via telephone or in person to ensure that the information is received. And for a lot of our clients, our social workers know, what the best way to reach it. So we're not using a one-size-fits-all. So next slide, please. So the loss of electricity for our county residents is not something that can be planned. Power outages, as I mentioned, can occur anytime, but most frequently they are with these high wind events, particularly in the fall and winter months. So after the Thomas fire, which the electricity company admitted that they were, their down power line was what started the fire, our local utility company, Southern California Edison, initiated more frequent public safety power shutoff events to avoid the wildfires. So in response to this happening frequently, we have implemented a variety of procedures to address the needs of people, older adults and people with disabilities in our area. So These include making sure that there's continuous contact with our social workers and case managers to assess that all of our clients' needs are being met. We partner with organizations such as our local Independent Living Resource Center to broaden our reach. And we use enhanced communication tools, including bilingual messaging, designed to help our clients prepare for the compromised ability to life-sustaining medical equipment, safe access to food and water, and home safety preparations like clearing hallways of clutter to avoid potential falls and having quick access to battery-powered lighting. Additionally, our great State Independent Living Center network, they've also secured grants for large battery storage devices so that people that are dependent upon electricity for the medical devices can, borrow these battery packs. And so when an event happens, they're okay. Next slide, please. So COVID-19. So California has been hit particularly hard by COVID-19 crisis. In recent months, statewide, 65% of the people that have been in an ICU have been over the age of 61. 83% of all deaths from COVID are people over the age of 60 as well. So our response has been vast. We immediately identified the needs of our older adults living in the area, as well as those with disabilities. And one of the things that we found early on is that people needed access to food and meal services, which I'm sure that this, is repeated throughout the country. So our senior nutrition program dramatically transformed to meet the community needs. Since March of last year, we have served more than 3.6 million meals to more than 25,000 people. Some people need assistance for a couple weeks, and some have received meal service since last March, which is fine. We want to be there for our community. So we work with 10 senior centers, 60 local restaurants, and World Central Kitchen to make all of this possible. We have also expanded to provide support for homeless individuals being sheltered in hotels during the pandemic, as well as COVID-positive individuals in isolation at home or in hotels without the resources or access to food. So we'll get a referral from public health saying, here's a family that's all COVID positive, please feed them for 2 weeks, and we will. The total dollar amount spent supporting our food program since last March is over $45 million at this point. Pre-COVID, my food budget was $2 million a year, so it's a huge increase. So along with this, we've received more than 70,000 requests for services, have made more than 300,000 deliveries to people's homes. We do have a team of staff, disaster service workers. Can't say enough about volunteers. People have done everything from working in the call center, packing food boxes, delivering meals, conducting porch visits, anything that we can do to support our community. We have ramped up our communication efforts with the community as well over the last year. So we took what we learned from the Thomas Fire and made sure that we are communicating, so that the community knows that there's access to food and to other resources and where to get it. We continue providing our emergency preparedness support. We've provided COVID care kits to the community. We have also took New York's great example. We now provide animatronic pets, which if you're not doing that, do it. People love it. It's life-changing for many people. And you look at it and you're like, I can't be that makes that much of a difference. It really does. This is not, I could do a commercial for them. It's been great for our clients, and we like it. We have also ramped up to provide rides to vaccine appointments because that's something that is a real need in the community. Also, rides to COVID testing appointments. We provide gurney transportation if that's what people need. We take the COVID home testing kits to people in their homes as well. We are also working with our library system to address equity and access issues. And so we're working with them with a partnership on two things. One, to reach out to grandparents raising their grandchildren through their mobile book program. So we've been really successful in finding people that we didn't know that were out there that needed help. And we're also partnering them on a digital divide project as well, which will provide Chromebooks and other equipment to older adults in the community through the library system. And we're also working with other county agencies right now on vaccinating homebound older adults and people with disabilities in their home. Next slide, please. So I will go through these quickly, but disasters do come in many forms and at any time, but the one thing we often forget about when planning for a disaster is the long-term impact on people experiencing the disaster. With the Thomas Fire, we saw the prolonged impact as people struggled to rebuild years later and the loss of what was familiar to them. It's not something that people get over in like 3, 6 months, a year. We are seeing it, 3+ years later. It still has had a profound impact on people. So with COVID, we're also seeing firsthand the impact of isolation, loneliness, and depression that it has on older adults and people with disabilities. And with so many people living alone and cut off from familiar support, it's even magnified. So I'm sure most of you are familiar with the study about the impact, on social isolation, and I think some of the stats were mentioned earlier, so I will not repeat them. But one of the things that we are doing that I'll mention is in partnership with the Meals on Wheels America, we started a letter of support campaign. And so where community members write, notes of encouragement and cards to older adults. And we put this in with our food boxes, deliver with home-delivered meals, and our community has come together and they write letters, year-round. And so far we've received over 10,000 letters from the community to older adults and people with disabilities. We're also doing porch visits as a way to keep our older adults engaged, which, for some, this is the only source of companionship they have if you live alone. We're also screening all of our callers that call into our ADRC for depression, extreme stress, family loss, suicide ideation, and really we're looking at if we need to intervene and what services that we can provide. So there is a questionnaire that everybody is asked, and they're connected to services depending on how they answer. Next slide, please. So we have a large dementia-friendly program in our agency, and we also have an ACL grant that provides support for individuals with Alzheimer's or related dementia that live alone. And so in our planning, we always keep in the forefront of our efforts people in the community that need that extra support and planning for a disaster, during the disaster and after the disaster, in particular those with Alzheimer's disease or related disorders. So there are things that, that can be done. And so in the interest of time, I will go quickly. So, but just be mindful that, that there are people out there that have Alzheimer's and they do struggle with changes in routine, and they do suffer from, they're higher risk of suffering from isolation or depression. So when you're planning, just keep them in mind. Next slide, please. So creating a plan of action is really critical. Everybody knows the stuff on this slide. It's nothing new, but it does help. And so I would just ask that, think about when you're trying to figure out what your community is going to do and how you're going to prepare for the next emergency. Think about these things and what you can do. Next slide, please. So there are a variety of resources that we've used as an agency, and there's some of them listed here. I love our VC Emergency website, and that's our county website that contains all information for the community about disasters. And early on with COVID, we actually got them to post our links on this. And so people could go there for food or connect to our services. Next slide. And just to close it out, thank you for your time. Here's my contact information if anybody's interested in reaching out to me for any information, and thank you.
Thank you so much, Victoria. I hope you've all enjoyed the presentation today. We have a few minutes remaining in which we can try to answer some of the questions that we have received. We're not going to get to all of them. If we don't get to your question, please don't hesitate to reach out to the presenter so that you can, correspond with them directly. I'm just going to go through these questions in the order in which they came in. The first question was directed to me, and it says, from an agency's perspective, what efforts have been taken to better educate the community at large, especially with regard to financial exploitation, including utilities, and best practices in monitoring. I will tell you, when it comes to this COVID emergency, ACL is just now gathering data on these kinds of things, best practices and ideas from our states and AAAs. So certainly, to the extent that we can, we'll be keeping track of those and sharing them. I do want to point out a couple other things quickly. Our state health insurance programs known as SHIP and the Senior Medicare Patrol programs known as SMP, they've been keeping track of a lot of fraud-related activity related to vaccines and COVID generally, so they have been putting out alerts when that kind of thing has come in. And also just keep in mind, the state units on aging and the area agencies on aging always are doing outreach activities and educational activities related to abuse and neglect, including financial exploitation, and they will often work with financial partners in their states. So I urge you to reach out to those agencies to see what they may be doing. Okay, I'm going to go on to the next. The next question asked about Grandparents' Day being in September, and how can we possibly incorporate this kind of preparedness information for older adults around Grandparents' Day. I also want to point out September is National Preparedness Month. So a good idea would be to provide some brochures and materials related to preparedness planning at whatever events you're doing for Grandparents' Day and tie the two together. I'm going to go on to the next question. This came from Stephanie Marino. I believe, Greg and Becky, it's for you. And she's asking, how are you collecting your data and what automated system are you using?
Yeah, so it's a complicated question, but the data that we collect comes from our Compass assessment tool, and you saw what those data elements are. That then gets transferred from the counties. We have one system to our office. We are working, our vendor is PeerPlace, but most of the data that we crunch internally. We're now working with PeerPlace to be able to generate the types of reports that I need to make the case that I need, and to do the same for Becky and her membership. So the data is all collected as part of like a minimum data set, no different than you would collect to report to ACL on what you're doing, except ours is much more expansive, and it allows me to kind of slice and dice to make the case.
Excellent. Our next question relates to AAAs, and the questioner is asking, are the AAAs the 59 county-based area agencies on aging, and do they include offices, contractors, senior centers, et cetera?
No, so our network is, it starts with us, and then it's 59 county offices for the aging. New York City is one big one, even though it's 5 separate counties. And then the next level down is our 1,200 subcontractors, and they could be all inclusive, from legal services to home delivered meals to congregate sites to home care agencies, et cetera.
Okay. The next question, again, I think all of these remaining questions, Greg, are for you and Becky. The next question is, what percentage of older adults are you finding are technologically literate?
It's a great question. So 85% of the general public is connected in one way or the other, 20% older adults less than that. So it's about 65%. And that's, that's assuming that you live in an area that has broadband access, that you can afford the equipment, that you can afford the MiFi, et cetera. So, 20 years from now, hopefully we won't be having this conversation anymore. But, when we talk about our tech solutions, I want to just be very clear that that is not the solution. That is just one more tool in our toolbox. And old school ways of staying connected, like the telephone, face-to-face, things like that, we're going to have to continue to do, or folks are going to be left behind. You guys know the commercial, the Verizon commercial, and you look at the United States, pay particular attention to New York next time, because you'd be surprised how many spots in New York don't have the coverage that shows up in red. We actually look like Wyoming in upstate New York because most of the state is not New York City. So it's a great question, but there's other ways that we can do things. We can help to train a caregiver, for example, or a neighbor. People can be taught, but there's going to be a variety of folks who are older customers that are never going to be connected, and we have to, make sure that we use old school ways to stay engaged.
Okay, thank you. Next question for you, Greg. I think you started to talk about this in the chat box, but where can I find the unmet needs formula?
So I responded to that question. There isn't a formula. When I got this into the budget 3 years ago, I specifically, because this was state funding, I drafted the appropriation to bypass the funding formula. And what that means is that I could send money directly to where the need was. Now, Becky was the Franklin County director at the time, and I'll just give you an example. If the $15 million went through the traditional funding formula, Becky would have gotten $32,000 out of that $15 million. What we were able to do was actually meet what she needed, and I sent her almost $400,000. That's why that's so important, because the funding formula is great for general support, but when you're trying to target where the needs are, it doesn't work that way. And so, this additional potentially $27 million that we're going to get on top of the 15 will allow me to do the same thing, is direct it right to where it's documented and reported the needs are. I've got 6 counties that don't report any wait lists. That's great. That's a success story. And then I can redirect those dollars to where they're needed, not weighted based on the 60-plus population.
Okay. Thank you, Greg. I think we have time for one more quick question. Do Older Americans Act case management clients receive the comprehensive assessment that is done, or is that only for New York's Medicaid waiver clients?
So I think I saw that come out of Vermont. We're one of the few standalone state units. We do not administer any Medicaid waivered services at all. So all of our state and federal and local funding are Older Americans Act, are non-clinical, have nothing to do with Medicaid. So they are all, for the 5 core services, they are all required to undergo a comprehensive assessment.
Thank you so much, Greg. This is Rhonda here. I want to thank all of our speakers today. I am now going to turn things over to Kathleen Oddie for some closing remarks. Kathleen?
Thank you, Rhonda, and thanks everybody for joining our call today. As I promised, it was going to be a very exciting day filled with lots of data, information, and best practices. So thanks for hanging in there with us. I want to thank our fabulous speakers, Deborah Costa, of course, from FEMA, Rhonda Schwartz from ACL, Jean Bennett, SAMHSA, and our partners in New York, of course, Greg Olson and Becky Prevey, and Victoria Jump from Ventura County, California. Thanks to all of you for taking part in sharing your knowledge and information. But I also want to conclude this presentation by saying thank you to our partners at FEMA and the FEMA team that made this possible. What an outstanding effort it was to get this information to the nation about some of the promising practices and the Ready Senior events that are going on throughout our nation. So thank you again, and I'll turn this right over to Allison for her poll. Thank you.
I think Hi, Kathleen. Everyone, if you could see, there are 3 polls on the screen right now. We ask if you could please fill those out so can better inform the virtual offerings that we have going forward. If you'd like to see some of our future webinars, you can click on this link on the screen along with our previous webinar recordings. This webinar was recorded, and it will be made available on the FEMA website in a few weeks. We also have a newsletter if you'd like to receive updates from us, and of course, you can reach out to us at any time.